Okay, good morning. Omaha is with us. Our online participants are with us today. So we're going to go ahead and get started just a smidge early. As mentioned before, my name is Carrie Rossetti, the Senior Manager of Programs and Services. We cover Nebraska, Kansas, Missouri, and Potawatomi, and I'm thrilled to be with you guys today. First of all, a huge welcome and thank you to those who are viewing online and from Omaha. What a wonderful way for technology to be poetic, and as technology is permitting us all to be talking about the same thing, learning the same thing across a geographical span like Nebraska and Kansas City. Second, this day would not be possible without our sponsors, vendors, volunteers, and planning committee. Our volunteers have helped in many vital and meaningful ways, from making connections with the vendors you've seen outside to with the assistive technology experience, to ordering food, to connecting with speakers. Will the Trend Planning Committee and volunteers who have worked so hard to bring this together please stand and be recognized, both in Kansas City and Nebraska? Yes, thank you to Rebecca Barnes, Deanna Markley, Catherine Crittenden-Reed, Dan Dorsch, Lisa Aguilera, and Barb Harwick here in Kansas City. Mary McPartling as well is here helping today. And then Laura Pryor in Nebraska. Thank you so much for your help. This team put a lot of time and energy into planning the day, and we truly appreciate it. So as we thought about topics for this year's symposium, we engaged in conversations with individuals who attended Trend in the past, and we discussed ideas with our Clinical Advisory Committee, which is a group of professionals that make sure we stay to our high bar of evidence-based research and information. The topic of assistive technology really came out very quickly as a favorite topic of what to discuss this year. We do realize the value in using new and cutting technology and the things that we do that can increase our quality of life for people with living with MS and for researching further cures and ways to end and stop the disease. Our Mid-America chapter holds tremendous experience, professionalism, and passion for our shared cause. Our staff, constituents, and volunteers create a group that is vibrant, alive, fun, and thriving. Speaking of volunteers, it is my honor to introduce you to one of our MCs today, Deanna Markley. Deanna Markley is with the Mid-America Research Hospital. She's probably a familiar face to many of you. She's a physical therapist at the Mid-America Rehab Hospital outpatient program for about 24 years. This is June, so that's why I thought she might know some of you face to face. You want to come up, Deanna? Come on up. I'm still going to talk as she comes up. You're coming up here, aren't you? Yeah. She works with neurology patients and specializes in multiple sclerosis. She has set up an exercise group for MS patients after discharge from therapies. Deanna has been a long-time supporter of the MS Society. She has been a volunteer here with us for 18 years. She serves as the chair of the Chapter Programs Committee and is a member of the Kansas Government Relations Committee. Deanna also lobbies for the MS Society at the state level and has traveled to Washington, D.C. to advocate for federal policies, priorities for the MS Society. Deanna has received many awards over the years, including the Mid-America Chapter's Healthcare Professional of the Year in 2009, honored at the MS Mid-America Chapter Dinner of Champions, and was inducted into the National Mid-America MS Society Hall of Fame in 2010, and she has also received recognition for her exemplary service at Mid-America Rehabilitation Hospital. Without further ado, Deanna Markley.
Thank you, Carrie. I think that's way far too glowing. I love each and every one of you. That's why I've been working the number of years I have. Otherwise, I should be retired. Welcome to the Trend Symposium of 2014. It's been a delight to work on the committee, and we've had really kind of fun. It's been, work, but make fun of it, and enjoy it. Our topic today is MS in the digital age, from low-tech to high-tech. And I hope that each of you have taken time to visit the vendors that we have out in the lobby. And if not, there will be time for you over the lunchtime to go and visit with them. We've allotted a special time, more time, like I said, for the lunch so that you can revisit even if you have been there. I'd also like to talk about Dr. Huisinga's research project, and it's set up in the back of the room over here. I won't go into it because I'll let her tell you all about it. But she's doing lots of good research with some physical therapy students that are in their first and second year, I think is when we were talking. Anyway, they're helping out, so feel free to go visit with them. And we want to show you how the MS Society and the researchers are working together to help us end MS forever, which is one of the goals. We have a great program in store for you today, and think that you will leave with lots of new information, lots of resources, and hope that you've made contact with another person with MS. Because it's always good just to sit and visit, because you learn lots of things, at least I do, from each one of my MS patients. Remember that we are collecting questions at 10:30, so there's little cards on the table, so if you want to write down a question, and then someone at the table will take them, and then we'll pass them to one of the staff people. Our keynote presentation is by Dr. Jessie Huisinga, who will set up the tone for today's symposium. Dr. Huisinga is an assistant professor in the Department of Physical Therapy and Rehab Services at the University of Kansas Medical Center. She's also the director of the Human Performance Laboratory within the Landon Center of Aging at the KU Med Center, and is an affiliate faculty member in the Bioengineering Department at KU on the Lawrence campus. Dr. Huisinga completed her undergraduate degree in biomedical engineering at the University of Iowa. She then attended the University of Nebraska, Omaha, where she received her master's degree in exercise science, and the University of Nebraska Medical Center, where she received the PhD in biomechanics. She completed a postdoctoral fellowship with the Neuro Department at Oregon Health and Science University, where she was the National Multiple Sclerosis Society Research Fellow. Dr. Huisinga's research focused on understanding the underlying neuromotor deficits which contribute to mobility problems in our pathological population, and to improve treatment protocols related to these movement disorders. Please join me in welcoming Dr. Jessie Huisinga.
Good morning. Okay, we're ready to go. Good morning. I'm so happy to be here with you guys today. I was talking to someone else yesterday. They said, "Oh, what are you doing tomorrow?" I said, "I get to go give a talk to all the fantastic MS patients that we get to help with my grant." So I'm very excited to be here. I'm very excited that the chapter invited me to talk to you guys. Couple of things I was saying in the back of the room. Whenever they read my bio, I'm like, oh, it sounds like I'm like so fancy. I'm really not that fancy. Just call me Jessie. It's fine. My graduate students and employees of the Human Performance Lab are over here for you guys to chit-chat with. Hopefully some of you guys got to talk to them earlier, and we'll be here all the way through lunch as well. So what do I do? Well, my background is in engineering, and basically I'm interested in understanding sensory and motor problems that people have and how those sensory and motor problems affect their movement. I've worked with different populations, with Parkinson's patients, with vascular disease patients, but for the past 8 years or so, my research has really focused on understanding the gait and balance problems that people with MS experience. So first of all, okay, you guys know what MS is, but I'm going to give a few quick facts that are going to tie into some of my research hypotheses. So first of all, multiple sclerosis, it's an autoimmune disease. People are diagnosed when they're relatively young, usually between the ages of 20 and 40. It affects the myelin around the nerve fibers. And because of this, patients have significant problems with walking and balance. Up to 85% of patients with MS report problems with walking and balance. One of the reasons I was so interested in engineering and in biomechanics, my background, is because studying walking and balance is universal. Everybody understands what that is. And so it was very interesting to me to work with patients who have MS and try to understand the problems that they have, because the problems are so prevalent, yet people think, well, you're still able to walk, so what's the big deal? Oh, it's a big deal. Okay, so the question, though, is why do patients with MS have walking problems? What causes the walking problems? When I started working in this field around 2007, there was really no literature published actually quantifying the changes that occur in the walking patterns and that occur at the balance problems that occur in patients with MS. It was just like, well, you have MS, so you're going to walk differently. You know, you should rest a lot. That was really all that we knew. So my big question was, well, what causes these balance problems? First, let's quantify them. Like, let's define what the problems are, but then let's figure out what causes them. And then two, how do we monitor changes in walking, right? MS is a progressive disease. How do we monitor when someone's walking or balance is worsening? And when I started in this area of research several years ago, none of these questions had really been broached yet. So I'm first going to talk about balance control. And you think, well, balance and walking, like, it's all the same, right? No, it's not. So I'm actually going to talk about balance first, and then I'm going to talk about walking. So really quickly, a little physiology lesson. So you guys can go home today and say, well, I had a little mini physiology lesson. What information does every human being need in order to maintain their balance? Why can I stand here and not fall over? I take in 3 sources of sensory information. I take in information about my vision, so I can stand here and look at you lovely people, and I can see the walls around me, and I get information about my position relative to you and relative to the walls. That's what I can see. The vestibular information, so your inner ear, you know, if you've ever gotten dizzy, it's because your vestibular information is altered. And then the somatosensory information. Somatosensory information is the information that your body receives basically from the outside world. So in my case, I'm standing on the ground, and I know that the ground is not moving. I can touch the podium, and I get feedback for the position of the podium relative to myself. One thing I want to point out specifically about somatosensory information here, you guys can see, I'm going to use this side for my pointer on my right because I can't reach that screen with my pointer. I apologize. So I'm going to do the right-sided pointer. So remember this slide, right? We know myelin is affected. And there's loss of myelin in the nerves. And, okay, let me find my pointer. Loss of myelin also in the brain and in the spinal cord, okay? And then we look at our sensory information. How is our somatosensory information conveyed to our brain? Through the spinal cord. And then the brain figures out what's going on, and then it gives information to the muscles about how to move. And all of that information, again, is conveyed through the spinal cord. So if we have loss of myelin in the brain and spinal cord, and that's how the body is transmitting information about balance, we're going to have problems with our balance. Is everyone following along? Any agreement on that? And also, since I'm talking about all these science terms, truly feel free to raise your hand if you have a question at any point. So if we look at balance in the simplest way, is we measure balance while people are standing still, which seems sort of counterintuitive, like you're not moving, what's the problem? Well, what's interesting is everybody, whether you are an MS patient or not, when you stand still, you're still constantly moving. You're constantly swaying back and forth, okay? That's what we call postural sway. So even as I'm standing here, or where you are, if you stand up, you're still using your vision, your vestibular information, and the somatosensory feedback to maintain postural control, so you're able to stand there. Now, if we measure postural sway, we actually get information about your balance performance. So one of the pieces of technology that we're able to use in a laboratory-based setting is something that's called a force platform. That's up here. Basically, whoop, it's up at the top of the slide. Basically, a force platform is a very, very fancy scale, okay? But what it allows us to do is it doesn't just give us your weight, for example. It actually lets us measure the forces that you produce front to back, side to side, and up and down. So we can actually map your pattern of sway, okay? That's what this figure down on the bottom shows. So you stand on a force platform, and we can actually map your pattern of sway. And from your pattern of sway, we can get information about the amount of movement that you're showing, the velocity of movement that you're showing. We can quantify based on your pattern of movement if you're highly variable, meaning you're moving a lot in a lot of different directions all the time, or if you're not variable at all, meaning you follow the same pattern over and over and over again. And again, this is all just standing still. So what do we know about patients with MS? We know that patients with MS, standing still, eyes open, all sensory information available, we know that the sway area, meaning if we track their sway path, their sway area is much larger than in healthy controls. We know that front to back and side to side, they move more, okay? This figure, on the right side of the slide, the orange sway path is a healthy control individual. The black sway path is an individual with MS. And this is just a representative figure. Pretty different, right? So why is this important? It's like, well, yeah, so people with MS have, different balance. We already knew that. This is some of the first research to actually quantify that fact. So it's one thing to say, yeah, I have poor balance. Let's measure it and let's quantify it and publish information about it and share information about it. So we know that patients with MS, even with all of their sensory input, they have a larger amount of sway than healthy controls. We also know that if you take away one of those sensory inputs, their sway gets a lot worse. What do you think the easiest sensory input to take away is? Close your eyes. Yep, that's exactly what these studies did. They had patients stand there and close their eyes, and their sway got much worse. Basically, every problem that they had with their eyes open basically got amplified when their eyes were closed. So that indicated that patients with MS have a problem using their sensory inputs, because when you take one away, all of a sudden the other two can't compensate for that loss. In healthy individuals, when you close your eyes, your sway does increase also, but your other senses are able to compensate for that so that it doesn't become exponentially larger as it does in patients with MS. Another interesting characteristic is patients with MS, if you ask them, so they measured patients who were asked to stand and reach or stand and just lean to one side or the other. And patients, when they were asked to lean, they leaned much less than healthy controls. When they were asked to reach, they reached much less than healthy controls. The hypothesis being that they self-limited. I know my balance is bad. This person is asking me to reach way over here, reach as far as I can, but I know if I reach too far, I might fall. So I'm going to self-limit. And this has actually been repeated in several studies where MS patients, because of balance problems, they self-limit their performance in these goal-directed tasks. In another study, also just looking at balance, patients were asked to respond to a perturbation. So they were standing on a surface, okay, and the surface moved a little bit. Imagine you're standing on a bus or you're standing on a train and the train isn't moving and then it starts to move and you sort of get that thrown back feeling, and hopefully you're holding onto the bar or something so you don't fall, but you get that thrown back feeling. What happens in that instant is the train starts moving, your feet tells your head the train is moving, don't fall down, or your brain, excuse me, and then your brain tells the muscles, grab the bar, muscles in your legs turn on so that you don't fall down. Well, what they found is that in patients with MS, their response to that was very, very delayed, and they responded with an exaggerated response. So rather than simply correcting their lean, they actually had to take a step back. They weren't able to compensate from the movement. And again, this is with all sensory input available. So the information that was coming from the feet about the translation was getting to their brain late, and then their brain was late in responding and telling them how to correct for the perturbation. So all of those tests that I just mentioned outline some of the balance characteristics for people with MS. They're all done in a laboratory, right? So I do want to touch a little bit on how balance can actually be measured outside of a laboratory. So I mentioned the force plate, which is sort of the very, very, very fancy scale. Again, that example is on the bottom of the screen here. Well, we can actually measure some of the same outcome variables about standing sway using small sensors, using small accelerometry sensors, okay? The information gained is different, but we can quantify it and calculate basically the same outcome measures. So we can get information about the amount of sway, how quickly the person is swaying, what happens if we change, a sensory input, and we can get that outside of the laboratory. For example, if some of you guys saw our system over here earlier, those are accelerometers that we use. So we can place a small accelerometer on the lower back and measure sway outside of the lab with the same level of sensitivity that we are able to measure inside of the lab. So this is kind of fun. Have you heard of Nintendo Wii Fit, everybody? Yes, everyone's nodding, right? So what's interesting, the Wii Fit, it looks a little bit like my fancy scale, right? It's similar. I mean, it's the same idea, right? So there have been several studies, actually, specifically in patients with MS, that have used the Wii Fit as a balance training aid, right? So not everyone can travel to their physical therapist or can travel to a gym or can travel for whatever rehab therapy that they're involved in. So there have been several research studies in patients with MS where they take the Wii Fit home and they're able to use the board and the games associated with the Wii Fit in order to actually improve their balance. And the home-based training systems have been hugely popular. And it's just in the past about 2 years that research has started to be published in this area looking at the use of these types of exercise aids in order to improve balance outside of the laboratory, outside of the therapist's office. Another option for actually measuring balance outside of the laboratory, does anybody have an iPhone on them? Raise your hand. Or any smartphone on them. Raise your hand. Okay, so your smartphone has an accelerometer in it, okay? And applications or apps are actually being developed that we can use to measure, so that you can use to measure your balance literally wherever you are. So our lab is involved in a pilot study right now with a company who's actually developed an app and has commercialized the app for people to use anywhere, basically. So you would basically stand and hold your phone, this is an iPhone, but hold your phone against your chest and follow the protocols that are outlined. So the app actually says, hold it here, stand here, press this button, open your eyes, close your eyes, whatever you need to do. And then it gives scores. So it scores your performance. And so you'll be able to track your balance changes over time. Again, this is an application that's available outside of the laboratory that you could use clinically or just on a day-to-day basis if you actually wanted to track your own progress. This particular app is still under development, but as technology improves, these type of applications will definitely become more and more popular. No one stands still all day. Let's talk about walking. So I always start talking about balance because balance, just standing still, is a relatively easy task, right? Yet persons with MS and other neurological conditions show significant changes in their performance even in that simple task, right? So what do we think happens when we make it a more challenging task like walking, right? The differences become even greater. So in a clinical setting or in a research setting, there's different ways that researchers and clinicians can measure balance. One popular way is a gait right mat. Has anyone ever walked on a gait right mat or seen this? It's basically like a long piece of carpet that has sensors embedded in it. And as you walk on it, it sort of takes an impression of your foot with every step. And based on your foot placement, it's able to give information about how long your steps are, how wide your steps are, how many steps you take over a certain distance, your step frequency. And all of these measures, as you might guess, are different in patients with MS. Patients with MS take shorter steps, they take wider steps, they have a lower cadence, meaning they take a higher cadence, meaning they take more steps in a given distance than a healthy age-matched control would. And this is only looking at footfalls. Your feet aren't the only thing involved with walking, right? Let's look at the rest of the body, what's going on. In order to do that, a laboratory-based method that's used is 3D motion analysis. So we have the Human Performance Lab at KU is a 3D motion analysis laboratory. And so if you've ever seen how they make some cartoons, how they make video games, so the easiest example is how they make video games. If you've ever seen, they put the little markers or dots on the athletes, and then they film them, playing football or golfing or something like that. Has anyone seen this? Somebody nod? People are nodding? Okay, good. So they do that in order to create a 3D reconstruction of the athlete and make it into a video game or a movie or whatever. Well, we can actually do the same thing with anybody who comes into the lab in order to study their movement characteristics. So we're not going to turn you into a movie, but we're going to use the same technology to really quantify changes in walking patterns. So with gait analysis, what we can do is we can actually look at each joint specifically and understand what's happening at the hip, what's happening at the knee, what's happening at the ankle, looking at which muscle groups are providing enough force or not enough force. If there's a change at one joint, is that change being compensated for at a different joint, for example? All of this can't be done in your doctor's office when they watch you walk down the hallway. So this is a laboratory-based tool only. What's been found, oh, sorry, I do have a video of this. So this is basically what it looks like when we have a person come into the laboratory and we do the 3D walking assessment. So this person has markers, a set of 27 markers from their waist down to their toes. We only put markers on the legs because we're interested primarily in the motion of the legs during walking. You can also see as the person walks, they walk over that gray square, and there's a red arrow that pops up. So the person is actually walking over a force platform. So they're walking over that fancy scale that I mentioned earlier. So what we're able to do is combine the information that we get from the markers, so we can quantify exactly how each joint is moving relative to the other joints. We also get information as they walk over that fancy scale about how a person carries their weight. Are they sort of stomping on the ground? Are they carrying their weight evenly on both feet? Is there sort of asymmetry from side to side? We can combine that information and we can actually look at how each joint is specifically contributing to the overall walking pattern. And what we find in patients with MS is that every joint is a little bit off. Okay? So what we find in general is that in patients with MS, their muscles are not producing the same amount of force that you see produced in a healthy individual. Okay? So for example, the easiest spot in the cycle to understand this is when you're walking and you're about to take your foot off the ground, you push off the ground, right? Your ankle pushes off the ground, and then your leg is in the air, and then you put it back on the ground. Does everyone follow that? So in patients with MS, for example, just before you take your foot off the ground and you have to push yourself off the ground, MS patients at the ankle, they don't produce enough force. The muscles around the ankle don't produce enough force in order to really propel the leg off of the ground. What's interesting about this and why it's important is because that doesn't necessarily make you walk slower, okay? And how is walking often tested? With a timer, right? So they'll have you walk a certain distance. Okay, how long does it take you to walk 25 feet? How long does it take you to walk 40 feet, okay? So what we found with 3D gait analysis is that you might walk normal pace, but your muscles are still not producing the appropriate amount of force. So it might look like your walking pattern is okay because you're able to walk 25 feet in less than 5 seconds, but there are underlying gait issues that are present even before you start limping and start needing any sort of external walk aid. And this was really one of the first studies to examine those issues in MS patients ever. So that sort of take-home message is don't assume just because someone is walking at a normal pace that they don't have any sort of alterations in their gait mechanics, because it's very likely that they do. So outside of the laboratory, everything I just described, you would have to come to the lab, you would be there for about 3 hours. We're fun people, but that's a long time. And after you leave, it would take us about probably around 8 hours of post-processing to really get some final numbers to quantify your gait. That's a long time, right? So a way to measure walking, maybe not with the same level of sensitivity, but just as importantly, outside of the lab, is actually using, again, some new technology. So there are accelerometers that are used frequently in research. These accelerometers are, you would place them, for example, like on your belt loop or maybe around your ankle, and then you would wear it every day for a week, for example. And all of your information is actually stored in the accelerometer, and then you would mail the accelerometer back to the researcher or to the clinician, and that person can then download your walking habits for the last week and look at patterns and changes. There's a research group at the University of Illinois Champaign-Urbana who's been using this type of technology for years, and they've published extensive data on the amount of physical activity in persons with MS and general walking patterns. Fitbit. Anybody have a Fitbit on? Have you seen a Fitbit? Yeah, a lot of people have seen them. It's the same technology, just a little more streamlined, right? Just made a little bit more accessible. So a Fitbit, again, it's a step counter, right? So it gives you information about the amount of activity you're doing, and you can also track sort of trends in your activity. A lot of patients that I talk to, depending on their medication, depending on the day that they take their medication, their activity level might go down. And then they feel better, activity level goes up. So what's interesting about the Fitbit is it's sort of a self-tracking mechanism. So it's not going to give you information about which muscles are activating and which muscles aren't activating, but that might not be necessary. It may be sufficient for you to just track your day-to-day activity, the number of steps you take, and it could be they could be indicators of overall changes in health status. If you and your clinician, whether that's your therapist or your neurologist, notice, for the past month, you've been taking fewer and fewer and fewer steps every day, what's going on? Because according to your timed walk test, it doesn't seem like your walking's changed, but your overall amount of physical activity has changed. So that's something that could be monitored with something like the Fitbit. So I just went over some of the walking and balance changes that we see in MS patients. So why? Why do these changes occur? It's not sufficient to say, well, this person has MS, so they walk differently. Why do they walk differently? What about the disease process causes these changes? So I talked earlier when I was mentioning changes in balance. We know that patients with MS have altered response to perturbations. It takes them longer to respond. When they do respond, generally they have to take an extra step. They can't correct from the perturbation. We know that the muscle activation of the legs, sorry, did you have a question? Okay.
What does perturbation mean
In this context, so this goes back to the example that I gave earlier, for example, when you're on a train or a bus, for example, and it goes and you're not quite ready for it, and you get that sort of thrown back feeling. Another example, we live in Kansas, it snows a lot, you're walking on the sidewalk and you step on ice. And all of a sudden, your foot moves and you didn't expect it to move. So that would be a perturbation to your balance system. Same example. So in patients with MS, the response to that perturbation is delayed. And so the response is exaggerated. You have to take an extra step, for example. We also know that during walking, the muscles don't provide enough force. They're not activating enough during gait. And so all of the joint mechanics are affected, And another study, they actually measured how long it takes for information from the feet to get to the brain. So when you step on that ice, how long does it take for your feet to tell your brain, we're going to fall down, do something, that information is significantly delayed in persons with MS, and that's been measured directly in nerve studies. So one of the core hypotheses to my research is let's really look at this delay that's happening. Muscle activation is delayed, sensory information, messages between the body and the brain are being delayed. What if that's one of the primary reasons that patients with MS have walking and balance problems? So that's what we're investigating. I told you I love to come and do anything for the National MS Society, and one of the reasons that I am very happy to be here today is to tell you guys about a research grant that I actually received this year to examine that question exactly that I was just talking about. So this year, we were funded by the National MS Society. It's a 3-year research grant, and it just started in April. Previously, we received a small pilot grant from the Frontiers Foundation, which is a KU-affiliated foundation. And so we actually started work on this grant a year ago in March. okay? And the goal of the grant is first to characterize why we see these problems in gait and balance in patients with MS, and to identify outcome measures that are very sensitive to measuring those problems. And we're going to do all of that using wireless sensor technology, so that you don't have to come to the lab for us to study walking, so that you can do it at your doctor's office, at your physical therapist's office. So a little bit about the technology we use. You guys saw we have sort of the station set up over here so you guys can see it. So what's nice about this technology is it's very small, it's very portable, it's very user-friendly, if you will. There's no wires, there's no extra equipment that's required. You need a laptop and you need the wireless sensor system. The inertial sensor, it has an accelerometer in it. So the accelerometer in this system is the same as the accelerometer that was in the red sensor that I showed, the Actiraf accelerometer. And then there's some other sensors that give us a lot of very specific information about your movement. So for example, if you put one of these sensors on your arm and you swing your arm back and forth, I can calculate the rate at which you're swinging your arm. I can calculate how quickly you're changing direction. I can calculate the range of motion of your arm. So if I put them on both arms and both legs, all of a sudden I get information about how quickly your legs are moving, how quickly your arms are moving, your range of motion, for example. I put them on your trunk, all of a sudden now I know what your trunk is doing during walking as well. So we use, it's a 6-sensor system, okay? We get information about your upper limb movement, your lower limb movement during walking, and we have people actually do a turn as well. So you walk, turn, come back. So we get information about how long it takes you to turn, how much your upper body moves during the turn, how much your lower body moves during the turn, and so on and so forth. We also have people do that quiet standing task. So it sounds boring, but you just stand there, okay? And we're able to measure your postural sway area, your sway rate, the amount of motion that's occurring, and all of this we can do in about 5 minutes or less, okay? What generally do you do when you go to your doctor right now and they want to look at your walking? You walk down the hall and they watch you, right? So what we're trying to do is come up with a tool that's much more sensitive and gives us a lot more information about your walking pattern, and that's what this system allows us to do. So why is it insufficient, or why would it be better to have a more sensitive tool? Well, several reasons. First of all, a quantitative movement assessment tool like the wireless sensors that we use, they'll be able to identify a lot of different deficits, right? So you guys see these are all the different variables we use. So we could find changes in walking performance in any of these variables, right? As opposed to just measuring walking speed. So we can identify if there's a deficit that exists much earlier, meaning if there's a walking problem, we're going to know about it before that person is in need of like an external walking aid, for example. We can determine whether or not there's a progression in changes in movement and balance over time. It helps us establish a baseline performance. For example, if an individual is going to begin a new physical therapy regime, let's see how you're doing before your therapy, and let's see how you're doing after your therapy, and let's measure that using very, very sensitive tools. The nice thing about a mobile assessment system as opposed to a laboratory-based assessment system, I already said, if you guys come see us in the lab, you're more than welcome. You're going to be there for about 3 hours, and then after you leave, we're going to spend many more hours measuring and processing all of the information. There's only one lab, so if you live, 300 miles away, you would have to drive to the lab and so on. The lab is very expensive, very expensive. That's why there's only one in the state. With the mobile technology, we can take it anywhere. It can be in a doctor's office. It can be in a therapist's office. The relative cost is much, much, much lower. The ease of using it is much, much, much lower. And the availability can be much, much higher, meaning these types of systems could be available in many different offices and clinical locations. So I would love it if you all came to see us in the lab, but it's not feasible. And we want to be able to get as much information as we can, and so using mobile technology will allow us to do that. So the specific aims of the grant. So I told you guys earlier about those delays in response to perturbation. I call those sensory motor delays. And what we're hypothesizing is that those sensory motor delays are really important, and that those delays are really are strongly related to a lot of the gait and balance problems that people with MS have. So what we're going to try to do is figure out, using these wireless sensors, what are the measures that are the most sensitive for people with MS. And the reason I say for people with MS is because across different conditions, the measures that are important are likely different. Let me give you an example. In persons with Parkinson's disease, using the same system and looking at the same outcome measures, it's been shown that arm swing changes dramatically in people with Parkinson's disease. It's very asymmetric. One arm they'll sort of hold against themselves, and then they'll swing the other arm. So that's a very sensitive measure for people with Parkinson's disease. It doesn't show us anything in people with MS. So when I say we have to find the most sensitive measures for MS, it's because the measure for Parkinson's patients, the measure for a stroke patient, is likely different than what's important for persons with MS. So the goal of AIM-1 is figuring out which measures are going to be most important, and what we hypothesize is that the measures that are most important are going to be the ones that are the most related to the sensory motor delays that we see. AIM-2 is let's measure those sensory motor delays outside of the lab. Let's use the wireless sensors to measure sensory motor delays. And that's difficult, and I'm going to get into those details in just a minute. And then AIM-3 is let's look at people over time. Okay? So we're going to finish AIM-1, and we're going to figure out these are the most important outcome measures for persons with MS. And then let's test our theory. Okay? So we're going to have people come back at different intervals over 18 months, and we're going to see if our new tool is more sensitive at identifying changes in gait and balance than the current clinically used tools. Okay, what exactly is this sensory motor delay I was talking about? So I described it earlier, right? You're standing on a surface, and the surface moves, and you're not expecting it, and there's a delay between the time when your feet say, hey, brain, we're moving, do something, and then the brain tells which muscles to turn on so that you don't fall down. There's a delay in everybody, in healthy individuals too, right? It takes time for that message to travel from the feet to the brain, and then for the brain to tell, the muscles in your legs to turn on. So this figure, I'm going to show you a video in a second of what this experiment actually looks like, but this figure breaks it down nicely. So we have the red line, you see the person who's standing still, and then when the red line is the onset of the perturbation, of when the surface starts to move. And you see the person starts to slide forward. And there's a delay. So we're measuring the muscles in their legs, okay? The orange line is a healthy individual, okay? So the orange line is when the healthy individual, the muscles in their legs turn on so they don't fall down, right? And so there is a delay between the red line and when the orange line starts, right? The black line is someone with MS. Okay, so their delay is much, much longer, okay? And so the difference between when a person with a healthy individual, when their muscles turn on, and a person with MS, when their muscles turn on, we call that the sensory motor delay, okay? In addition to that delay, the other thing that is pretty obvious in this graph, if you see the orange line, the muscle turns on, it gets pretty high, and then it just turns off, right? And the black line for the person with MS, it turns on slower, and then it turns off slower, okay? So so the muscle is activated later, and it doesn't activate as efficiently, okay? So we want to see, is this delayed sensory motor response, is that the most important thing that's going to give us information about walking and balance? If so, let's look at all of the measures that we're taking and see which ones relate to the sensory motor delay. Okay, I have a quick video. Hopefully this works. So this is actually our experimental setup in the lab. So what you'll see, a couple things. We actually have a very fancy treadmill that we can program to turn on very quickly and then to turn off. So that's our translating surface. And what you'll see too is the patient has a harness on, so they're strapped to the ceiling. They have, this is a little hard to see because of the lighting in here, but they actually do have some markers on their legs, and they have the wireless sensors on as well. And I have another picture after this that shows that in a little more detail. But I just want to show you guys what this looks like. So as the person goes, we don't tell them when we're going to turn it on. Boop. Okay. So So it's really quick, right? It's going to happen again. It's really quick. We don't tell them when we're going to turn it on, and we just tell them to maintain their balance. That's all we tell them. In order to maintain their balance, basically what has to happen is they turn the muscles on in order to prevent themselves from falling, but oftentimes they also have to take a step to correct their movement. So this is what it actually looks like. This is sort of a close-up. So we have the person, they're standing on the treadmill. We are measuring the muscle activity in the muscle on the front of their leg, and then their calf muscle, okay? And another little physiology lesson, you can measure that because your muscles actually put off electrical activity when they're firing. Okay, so when your muscle is like clenched, it's actually putting off electrical activity. And we measure that using EMG sensors. So this is what the EMG activation looks like in an actual patient. I showed you the pretty graph with the orange line and the black line. This is what it actually looks like. But what you can see here is sort of the background, the person standing. All of a sudden, the muscle fires quite a bit, and that's what we're looking at. We're looking at when does that firing start, and we're able to figure out when the treadmill starts and when the firing starts, so we can look at that timing difference. And so what we find is that those postural responses are much longer in patients with MS. And I have this broken down. The healthy controls are in red, mild MS are in black, moderate MS are in gray. Mild MS are patients who complete 25-foot walks in less than 5 seconds. So according to standard clinical mobility measures, the black group here, they're normal walkers. Okay, the moderate group in gray, they do their 25-foot walk in more than 5 seconds, so they would be classified as having walking problems. The take-home message here is the normal walkers in black have significantly longer postural responses than the controls. So even though they're able to walk quickly, there's significant changes in their postural control system. When we measure, okay, why did I have that here? Oh yeah, okay. So we want to measure and see if these sensory motor delays are related to their balance issues, right? So we're able to measure their balance and their sway pattern using both the force platform and the accelerometers that we have over here. And what we found, not surprisingly, is postural response latencies, or excuse me, the sensory motor delays that we measure are significantly related to the amount of sway a person has, to the timing of the person's sway, to the total sway area. So basically, the longer the latency, the longer it takes for those muscles to turn on, the more sway a person has. The greater the amount of sway, the greater their sway velocity is. This is one of the first studies really looking at why are these problems present. Why do people with MS have altered balance? One of the reasons is definitely because they have sensory motor delays. Now, we also looked at the relationship between sensory motor delays and what's happening during walking. And we found people with longer sensory motor delays have reduced power output at the ankle and at the hip. Okay? So remember earlier, every time you are walking and you go to push your foot off the floor and you don't produce enough muscle force, the less force you produce, the longer your sensory motor delays are. So again, this is one of the first studies really looking at why do people with MS have walking problems. Sensory motor delays are definitely an issue, one of the issues. I'm going to skip this for time. Okay. So aim one. Okay, aim one of the grant is for us to figure out which measures are most sensitive. So what I'm going to say is everything is in progress. So here's our current status of the grant, okay? So we've been collecting data for about a year. We have over 80 persons with MS collected and 40 healthy controls. Initial analysis of the data shows that there's a lot of motion happening at the trunk during walking that's related to sensory motor delays. Excuse me, and the sway variables that we see are significantly related to sensory motor delays. So initially, the variables that we would identify as important considerations during walking would be the trunk motion, and then also measuring quiet standing and looking at the sway variables collected using the accelerometers. Aim two. So aim two, remember I said we want to measure those sensory motor delays outside of the lab. Right now, we have to have the person come in. They're on the treadmill. We use the EMG sensors to measure activation of the muscles in the legs. We have to use the treadmill. We have to use the motion capture system. What if we're able to measure sensory motor delays using only our wireless sensor system? That would be cool. So that's what our aim 2 is. So what we're using is a push and release test. And the push and release test it was actually developed for Parkinson's disease patients, okay? So we've adapted it and we're using it with MS patients. And basically what the test is you stand. It's almost like the trust test, you know, when you're like, catch me, don't let me fall. So you stand, and the tester would stand behind you, and you would lean back into that person's arms, and then they let you go, and you catch yourself before you fall. This is kind of what it looks like. And I'll point out what we're measuring during this, okay? So you see the person leaning back, and what I want you to notice is their toes come off the floor. So their center of mass goes behind them, okay? So in this setup, the person has to take a step. There's no way you can correct without taking a step, because all of a sudden, all of your weight is behind you. And so when the person lets go, you have to take a step back or you will just fall. So during these trials, you'll notice we have the accelerometers on the person, the little black dots you can see. And we also get information, I should say we're also able to measure information about the movement of individual limbs as well. So what we're looking at, this is an example of actually measuring the timing from when the tester takes their hands off, okay? That's the black line here, okay? And the blue lines are traces of the person's foot moving, okay? So if we do it over and over and over again, you see here's where we take the hand off, right? And then there's a little bit of a delay, and then the person moves their foot to catch themselves so they don't fall down, okay? So remember when I was talking earlier about how you're standing there and the surface moves and there's a delay between when your feet tell your brain something's moving? So we're doing the same thing here, only now instead of our perturbation being a surface translation, our perturbation is the push and release test. Does everybody follow that? So what we found so far is that we can actually measure the latency between when the tester lets go and the person starts to take a step back so that they don't fall down, okay? And when we measure that, we find that step initiation is strongly correlated with their muscle activation during the standard translating task where we use the EMG to measure muscle activation. So people, when they're standing on the treadmill and we perturb them and their muscles turn on and we measure that delay, the longer the delay, when we have them do the push and release test, the longer it takes for them to initiate the step back once they're let go, okay? So we're trying to quantify that sensory motor delay using the sensors only. And so far, it's definitely looking like it will work. We're still collecting data. Aim 3 of the grant is to track people longitudinally, so they'll come into the lab every 6 months for 18 months, and we'll measure their walking and balance, specifically using the measures that we identify in Aim 1. We don't know much about this yet because it just started. We just started bringing people back in the last few months. Our goal is to bring 40 patients into the lab at 6-month intervals over 18 months. And right now we have just started our first repeat collections on less than 10 subjects. So Aim 3 is basically still unknown at this point. So some take-home messages. I'm pretty much on time, so we're good to go. When I started studying walking and balance changes in persons with MS, I started in about 2007. We didn't know much. We did not know much at all. There was really no quantification of the problems, and certainly no one had started investigating why the problems were occurring. This has changed a lot. There's actually an entire conference now dedicated. It's called the Gait and Balance Symposium in Multiple Sclerosis. So there's an entire conference for researchers to come who are devoted specifically to looking at gait and balance problems in MS, and that just started about 3 years ago. Much of the research, though, is still laboratory-based. It still requires individuals to come into the lab and for us to do our long protocols. There's a very large interest, though, in at-home measurement and at-home treatment options and using technology to facilitate those options. As I said, who has an iPhone, who has a smartphone, who's seen the Wii Fit? You know, those are all options and technologies that are being used currently in research studies to understand balance problems, but also to treat balance problems. To treat balance problems. Ultimately, I don't think I said this at the beginning, so I'll say it now. I'm not a clinician. I'm not a physician, and I'm not a therapist. I am an engineer. And I think anybody in engineering who's interested in using technology to understand these issues, our goal is really to assist the clinicians, to assist the physicians in improving standard of care and just giving as much information as possible to you and to your care providers in order to treat the disease process as a whole. So I have several people to thank. First of all, funding is provided for this study by the National MS Society, as I spoke about earlier. I worked very closely with Dr. Sharon Lynch, she's talking next, at KU Med. I'll say this to everybody now because I know several people have asked. We actually recruit for our studies exclusively through Dr. Lynch's office. The reason for that is she does several clinical outcome measures for us, and so it works much better for us to recruit through her, and she does a lot of screening for us, and it's fantastic. We also have collaborators at Oregon Health and Science University and some other people working with us on this grant at KU. And then the picture at the bottom is actually some students that just graduated from the lab, but this is us at the Walk MS event this year, which was a lot of fun. So I just want to thank everyone who works in the HPL. You guys get to meet them over here. And it's always nice for us to get outside of the lab and talk to real people, so we appreciate it if you want to come and say hi. And if you guys have any questions, I'd love to take them.
We do have some questions that came from the audience earlier. It's Carrie back here in the back, sorry. The question is, do you measure if we go off course when we walk with motion capture? And the second part to the question is, can you tell where balance problems are coming from when you do the balance test, from the brain or certain nerves?
Yeah, okay, really good question. Part one of the question, when we measure walking, because again, we're doing it from a research perspective, so we have specific goals in mind of the type of information that we want to gather. So when we have a patient come into the lab and we use our motion capture system, we're looking at very specific variables. Those variables are basically the movement of the joints of the legs, motion of the trunk, and how a person carries their weight. We measure all that using the FORCE platform. So while we can measure, for example, path integration, whether a person is walking in a straight line, whether a person veers to one side or the other, we have that capability. But in a research setting, generally we're focused on specific questions, and so that may or may not be our specific question. When we measure balance in the lab, that's a great question. Can we tell if the problem is because of delayed, sensory responses or the sort of the core problem? The answer is yes and no, depending on what equipment we're using to measure balance. If you come to the lab and we have you stand on the FORCE platform when we measure sway, we don't know, using only that tool, why your sway might be different. However, if you come in the lab, we measure your sensory motor delays. We have you stand on the FORCE platform with your eyes open and with your eyes closed. We might use EMG to measure muscle activation at the same time that you're standing on the FORCE platform. We can combine that information to get a better picture of some of your more specific problems.
Okay, great. How are you able to distinguish if the problems are symptoms of relapsing and remitting MS or just aging?
Oh, what a great question. Oh, wow, you guys.
The statement says I'm 71.
Hey, fantastic. So that's a really good question. So one of the ways we control for that is our inclusion and our exclusion criteria for our studies. So we actually don't include anyone in our studies who's over the age of 60 because we can't. The answer is you can't. If you have an individual who's, over the age of 65, who has multiple comorbidities, and we measure their walking, we don't know if the walking problems are because of MS or because of aging or because of vestibular problems. So that's a consideration for us in the research design. So we say, okay, because we can't really tease that out, we're not going to include people in the study who are over a certain age. We're not going to include people in the study who have orthopedic problems. If you have a torn ACL, if you have a hip replacement, you're not going to be in our study because we don't know if your walking pattern has changed because you have a hip replacement or because you have MS. So we account for that when we're designing the study and setting our inclusion criteria.
Okay, another question that came. Dr. Huisinga, you have done all this testing for research. Is there any way individual patients can go somewhere for similar testing to get a baseline of their current condition?
So Again, it's all research-based right now. I think if patients are interested in sort of their baseline balance or walking status, a physical therapist also has many tools in their arsenal to define, sort of a baseline status. So I would say, again, I'm not a clinician. I would say speak to your clinician about what would be best for you. Unfortunately, having everything at a research state right now is all very exciting, and it'd be great if every clinic had these sensors. We're just not at that point yet. So I would say talk to your clinician, and a physical therapist has many, many tools that can be used to establish baseline walking or balance performance.
Okay. A question came, how are biomarkers, or how are they used for selecting MS therapies, or how do you see them being useful in selecting MS therapies?
So it depends on the biomarker. I would classify our movement tests could be classified as a biomarker since it's a marker of biological function. So the answer is it depends on what biomarker is being looked at, and it depends on what your specific interests are. If we're talking about gait and balance outcomes as a biomarker of function, I think that, as I said earlier, we can use these outcomes, to establish a baseline performance to help identify the source of the balance and gait problems. Just for example, we're measuring these sensory motor delays. We find that sensory motor delays are longer in patients with MS, but not in every patient with MS. Some patients with MS have normal sensory motor delays, but they may still have walking and balance problems. So that gives us an indication that if you have abnormal sensory motor delays, you may or may not benefit from a standard exercise therapy, because exercise won't necessarily improve the nerve conduction speeds, but you might benefit from a drug therapy that helps improve nerve conduction speeds. Conversely, if you don't have sensory motor delays, exercise might be a great option for you, because if you improve overall physical activity and improve muscle tone, and possibly reduce spasticity, that might be enough to improve your walking. So from that perspective, using gait and balance outcomes as biomarkers might help identify which therapies are most appropriate for an individual. But biomarkers in general, it would really depend on what the biomarker of interest was.
Thank you for that. We got time for just a couple more questions. So I think we'll go with this one. You discussed the gait and perturbation.
Perturbation?
Yes, thank you. What about
today.
fatigue and how that plays into those factors, and also the question asked about heat or the weather and how you account for those?
Yeah, excellent questions. You guys are good at this. So again, from a research perspective, we control for all of those things in our research design. So we inadvertently, I don't want to say inadvertently, we ask patients questions about their fatigue levels. So we have sort of a baseline of their fatigue when they do come into the laboratory. We control the order that we do the tasks and how much activity we have subjects do so that we don't increase their fatigue. Same thing with heat. We're very sensitive to heat changes and things like that. So from a research perspective, we try to control for those factors. In the grand scheme of how those factors affect gait and balance, those are very important research questions that are still being investigated. Fatigue is probably one of the hardest, and you guys know this, but it's one of the hardest symptoms to categorize because it's so dependent on other factors. One individual might view fatigue in one perspective, and another individual who's at the same level of physical performance, their fatigue might impact them in a completely different way. And the other thing is, are you talking about like physical muscle fatigue, like you're standing for a really long time and your legs get tired, or are you talking about like a central neural drive fatigue where, your brain talking to your body is just getting really tired, and that causes sort of a central neural drive fatigue. So fatigue in itself is always a factor in the study design. How do we make sure we don't make the patients more tired? But in terms of quantifying how much fatigue is contributing to the gait and balance problems, I'm not going to lie, it's really hard to look at. But researchers are aware of it when they're designing their studies. And there are other studies that look specifically at how fatigue and physical and cognitive fatigue are related to walking and balance problems.
Okay, thank you for that. A couple more questions. What do you think, based on what you've seen, is the best thing a person can do to improve their walking skills? And we're going to add this question later too.
I'm not going to talk about that.
Okay.
Because we have much more qualified therapists and physicians talking later.
All right.
Yeah, so I'm actually not going to answer that.
Okay. And then, fair enough. What is the latest research information on controlling tremors? Are you aware of any?
That's an excellent question, and to be honest, I'm not aware of specific research regarding tremors. We don't exclude patients with tremors from our studies, and so that's not an exclusion criteria that I've read in many gait and balance studies in MS patients. So I would say that a lot of the current research findings that I did present would also translate to someone who does have tremors. But specific research regarding tremors, I am not familiar with, unfortunately. Yes?
There is a technique out there that's been used called balance. Using strategically placed in a vest that counteracts sort of the direction that
I'll repeat this.
Okay.
Yeah, so what Kirsten was saying was one therapy. Are you talking for tremors or just balance in general? Yeah, so there's a group out in California who has investigated the effect of balance-based torso weighting. So the idea is sort of you have a vest on and you're able to place weights in certain parts of the vest. It kind of looks like a fishing vest, if you will, with lots of pockets. And you place weights strategically based on your tremor and the direction that you would tend to have increased sway in that direction. And so you can reweigh your torso in order to sort of offset the directions that falls might occur in. Is that it? Yeah.
Great. Well, will you please join me in thanking Dr. Huisinga for her time today?
Thank you.
Thank you so much. And as Lisa, our next MC, makes her way to the stage and our neurologists make their way to the stage, I again want to draw your attention over to where the study is happening. And on the lunch break, maybe you can come by and see what she was talking about and get to experience it. That's what today is about. Some of the vendors may still be outside as well. Okay, thanks. Lisa.
Good morning. My name is Lisa Aguilar. I was a physical education teacher and coach for 17 years before retiring in 2010, and I currently work part-time for my family small business. I was diagnosed with MS about 6 years ago. I was inspired to do more for the MS community by my physical therapist and now friend, the amazing Deanna Markley, which we heard from earlier. This is my first year volunteering with the MS community, and I am truly, really enjoyed working on the Trend Planning Committee. It is my pleasure to welcome Dr. Sharon Lynch and Dr. Christine Boutwell. Dr. Lynch is a neurologist and professor and director of the MS Clinic at the University of Kansas Medical Center, specializing in MS. She has done extensive research in MS and has served people with MS through her commitment to the MS Society. Dr. Lynch currently serves on our chapter board and as chair of our clinical advisory committee. Dr. Christine Boutwell is a neurologist at the St. Luke's Marion Block Neuroscience Institute. She has been in practice at St. Luke's for 14 years. She completed neurology training at the University of Kansas. Her primary interests are multiple sclerosis and the acute treatment of stroke. She has participated in several clinical trials regarding the treatment of multiple sclerosis and acute stroke intervention. Thank you both for being here today. Each neurologist will spend about 10 minutes talking about their perspectives around the use of assistive technology. We will then present the questions you wrote out earlier for their feedback. Please join me in welcoming our panel. And Dr. Lynch, would you care to start today?
Sure.
Thank you.
I think I'll come up there to talk.
So, good morning.
I don't know how old, I heard that at least one person in this audience was 71, and so they probably joined me in feeling a little bit overwhelmed over the years by the intrusion of technology into our lives. We have all many of us have gone through transitions from a time when we didn't even know what a computer was to a time when we touch our computers and work with them every day. And many people have these little smartphones, and I made it to my here today by taking my Garmin out and telling it to get me to KU, the Edwards campus. And so we are all kind of in this boat where we've got this morass of technology surrounding us all the time. Some of my friends accuse me of being what we call a Luddite, that is somebody that doesn't like technology. And there's some truth to that. But overall, I really believe that we do need to start embracing a lot of the changes that we have and using those to our greatest advantage, because there are things about technology that really can help, particularly people with disabilities, to live closer to a normal lifestyle. And that is so important, to find the things that really work. There are also going to be a lot of gadgets. And those gadgets are not necessarily going to all be good for you. And you might try some things and think, oh, I'm going to spend this, giant amount of money on this piece of equipment, and then we find out later that it's a piece of junk. And we just wasted all of our money. I had a patient once who bought one of those beds, that allows you to sit in all different positions and stuff like that, spent like $1,400 on it. Not a good idea. She bought it from a TV ad. Turned out not to be at all what she expected. Never could get anything, so her $1,400 was gone, but she didn't get what she wanted. So this is my cautionary tale. But everything has changed. We use electronic health records now, and those have been both a great boon to us, and they've been a great pain. There are now apps for almost everything you want to do on your smartphone. Some of them can be really helpful, like the ones that tell you that you forgot your medicine, or that help translate something that you need, or give you directions to a place you need to go. We have newer and better ways of doing braces and foot lifts and things like that. We have the little arm things that help us to position our arms better and help us to increase our strength and coordination. There are all kinds of technologies and technical devices, and I think I'm not going to go through a list of all of those things, but I will say that, when you are dealing with something, sometimes you can sit down and look at how can we use our computer, an electronic device, some kind of a mechanical device, something that will allow me to do the things that I haven't done, that I can't do very well for myself anymore. And by the way, that's been going on for longer than we've had computers. We've had so many things that we use that have nothing to do with computers that do that. The AFO brace, which we still use a lot of, many of the pieces of equipment that we see as standard. Probably one of my favorites these days is and I don't use it, but many people do, and that's the voice-activated computer, where you can talk to the computer and say, either send this message or write this message or whatever, or you tell the computer to do something and it does it for you, and you don't have to even strike a key. So there's a lot of technology out here today where people are going to show different things. I would say embrace the technology, look at it and see what kind of wonderful things are out there that can help you, but be just a little bit wary and don't buy a pig in a poke.
Thank you, Dr. Lynch, very much for that. Christine?
Well, I don't really have much more to add to that. I mean, I agree with Dr. Lynch. Maybe I'm a little less resistant of technology, maybe. because I wasn't going to say that, but since she said that, I guess the younger generations, you know, you always ask a child how to help you when you can't figure out what to do with your phone or your computer, because your 5-year-old can, your grandchild can. So definitely I think there's lots of roles in helping patients as far as in all the ways that were mentioned that I think are good. So I was really not going to prepare anything to talk, but just wanted to answer questions. So thank you.
Well, you can answer one. How do I turn this on?
There's a switch on top. Oh, technology.
And see, you can tell that I'm a Luddite.
Okay, just a quick reminder, if you have questions for the neurologist, Susan Engel, our VP of Program Services and Advocacy, will be circulating to pick up your questions. I do have questions here for you already, though we collected earlier this morning. So I'll start with this one. I seem to have more trouble with walking movement on the left side of my body than the right side. Why is that? Does that correlate to where my brain lesions are?
You know, it's interesting. It should. It really should correlate with where your brain lesions are. But many times when we look at the MRI, we can't necessarily see that. There's no doubt that in some way, one of the lesions that is causing trouble in that person's case is probably located on the opposite side of the brain, the right-hand side of the brain. But when you look at somebody's brain MRI, many times you see equal numbers of lesions on both sides, even though the person is describing one problem or other.
Yeah, I would agree. I mean, definitely every lesion that we see on your images don't necessarily mean an exact symptom that you will have, because several patients can have lots of lesions and maybe not have any symptoms. So.
Thank you. Dr. Lynch, will you scoot that microphone a little closer, please? Thank you.
I'm here.
Okay, thank you. Okay, great question. Next question is about color spots in the eyes. What causes color spots in the eyes, foot drop, leg pain? It's just about questions about what causes those. Christine?
Color spots in the eyes, color that they can't see, or maybe seeing colors that aren't there. You know, we would worry about problems with your optic nerve, damage there causing issues with color, or even lesions in the occipital part of the brain with scars and things that are there. Pretty much foot drop could be caused by lots of different things, but you know, lesions in the spinal cord or in the brain. Pretty much the symptoms that you have likely have to do with demyelination somewhere in the central nervous system, but there's also probably denervation that's happening and things we can't see that are leading to problems too.
It's also true that sometimes color spots are a symptom of a medication. You can get funny reactions that can do that. As far as that's concerned, you know, in general, the brain and spinal cord and the optic nerves are often have areas of damage, and through those areas of damage there is a loss of the myelin, which is the insulation on the wires as you think about it, causing short circuits when that's not there, and some of the nerves are also gone. And so as those nerves are not present, then you can't make them all do the movements that those nerves or areas allow you to do. And often when you know, it depends on where that is as to what the symptom is going to be. But sometimes you have to have a microscope to know that. One of the more interesting things about that is the heat thing, because many times many people with MS have trouble with the heat, and they talk about it. And what appears to be happening is that the myelin, as I said, is the insulation on a wire. And when you have an electric circuit, maybe you don't know it, but many electricians do, that it's the heat. Often during the heat, an electric circuit is more likely to short out because there's more resistance in that electric wire. Well, the same thing happens in the brain. When the heat goes up, there's more resistance and more areas can't get through. And so those things happen, like increased foot drop, increased blurred vision, increased weakness on one side of the body, increased fatigue, that are so well associated with many people with MS. The good news is that that usually tends to be temporary, and when you stop being hot, the resistance goes down and the movement through the wire starts going back to normal, or you're normal.
I don't know what this question that was just periodically at night I will get like a flash of out of is that related?
Could you repeat the question so the people in Omaha can hear it?
Flash of light, like a spark that out of the very corner of my both my eyes, but only at night usually.
So he was describing a feeling of a flash of light that suddenly comes across his vision just at night, and I don't know how to answer that question. I haven't seen that.
Wondered about it. I asked my doctor.
Yeah, and they didn't know.
It probably might have to do more with a retinal problem, and
Probably,
and you
yeah,
know,
it could.
probably not maybe not
It
related
may
to
not
MS.
be related.
Yeah, definitely can see flashes of lights with migraine. Someone brought up in the audience, and those types of things too. So may or may not be related.
Great. Thank you for that. A couple of questions came through regarding biomarkers. One was brought up in the session with Dr. Huisinga. So I'm going to try, there are 4 questions. The first is, how do you determine individual biomarkers? How do you then determine which therapy to use? And then, yeah, how do you use those in your practice and making ideas or for the therapies you use, the modalities?
You want me to answer that? You can start. Okay. So biomarker, the term biomarker is really a very kind of loose term, and different things can be counted as biomarkers. Some people think of a biomarker as a blood test that looks for a specific thing, but there are also other biomarkers, including MRI scans and other factors. As Jessie was talking, Dr. Huisinga was talking about that you could possibly use as a biomarker her testing on gait and balance. And so it depends on the biomarker what you're going to do with that information. Right now we don't have good blood test markers that say, well, if this person has this, this feature in the blood, they should be on this drug. And so we hardly ever use that in clinical practice at this time. There's some stuff that's looking like it might be interesting, but it has not yet really reached the place where we do that in clinical practice. We do say somebody has a low vitamin D level, I'm going to replace it. We do say this person's MRI scan is looking like they're worse this year than it was last year, and therefore I think perhaps we should consider changing from one medication to another. Or this person's MRI is looking stable over this last 2 years, and therefore maybe we need to stay the course, even though they're not happy with me because they want to change to a pill. So sometimes we use that sort of a, quote, biomarker. You could theoretically say a biomarker is how many exacerbations does somebody have, or how many, how much worse are they, or how much better are they from this year, from last year. And we use those sorts of things for clinical decisions all the time. Is their drug working? Is their drug not working? Are they going to have a lot of trouble because they've had a lot of trouble in the last 3 years? They've had, 5 exacerbations. Boy, I think I might want to do more. If they've had 1 in the last 2 or 3 years, then I may choose a different drug or a different mechanism of action, method of treating the patient. How much side effect am I willing to accept given the person's history in the last few years?
I think probably the decision for what medication you choose is so complex. I mean, I wish there was a biomarker that made it a lot more easier, but I think it really has multiple factors about, patient comfort and what they expect and what they're willing to tolerate, as well as maybe what they've been on, what their history is, what the MRI and those types of things look like. I think it's so different for everybody because everybody's MS is so different that there probably never will be a biomarker that tells us exactly what to do with each patient, but I think it's really complex.
Thank you. Speaking of MRIs, we have a couple of questions around those. One person who was diagnosed 11 years ago was told they should have them every 2 to 3 years. How often are MRIs necessary? Was a theme. So, what would you suggest on as far as quote regular MRIs?
I really don't think that there is a right answer to that question. I think that depends very much on what's going on with that person and how their MS is going, what type MS they have, and how they're being treated. And I think that's an individual decision that needs to be made between the patient and their doctor.
And I would agree wholeheartedly. I may use MRI maybe more in the beginning than I do later, but there may be other factors. Maybe patients aren't able to have an MRI because pacemaker or spinal cord stimulator or something else. I think there's a lot of other factors into that. I do think that MRI, though, I think it's one of the better things that we have available to right now to look at disease activity in addition to the clinical picture. So how the patient's doing. Sometimes patients can be doing just fine and their MRI can be really have a lot of lesions that makes a lot of difference. And I would be concerned that we're not being aggressive enough with their therapy. So I do think it's important.
Yeah, I think we still need to remember that the most important thing is how the person is feeling and how the person is doing. The MRI, it can be a big and helpful tool to us, but it should never be the only thing we look at.
And that's a very interesting question just for my own dialogue here, is that it's hard to remember in your doctor's visits what's been going on all the time. So some of the technologies available can track that for you. And Dr. Huisinga mentioned some of that. And would that be something that would be helpful for you when you're working with someone?
Yes.
To have that kind of, yeah. So again, not to be, afraid to use the technology and to ask questions to your healthcare professional.
Yes.
Okay, I guess that really wasn't a question, sorry. Okay, so what do you do with accelerator information after being tested?
Actually, I don't do anything with it right now. It is still experimental. We don't actually know what it means clinically yet. We hope that we will know. We hope that it will be able to tell us more about how people are doing. But as it stands right now, that's simply information we're learning. Hopefully at some point it will be another way of us determining somebody's disease disability. How is the disease affecting them? And it may help us to answer a lot of questions that I get every day about why this person tells me they stumble and fall when I don't see anything wrong. But in terms of what do we do with it right now, we can't do anything with it right now because we have no real basis upon which to use it.
Great. Christine, you want to add to that? Okay. Okay, so a question about healing nutrition. What are your opinions or feelings about diets? And Dr. Walls is in parentheses on one of the cards. There were 2 questions about that.
I'm going to say that anytime somebody says that they did this themselves and therefore it must work for everyone, they have a problem in their judgment. And I have seen many, many diets come and go in MS. And having been studying MS for 30 years, I have seen a lot. And I have seen many things where somebody wrote a book and said, this is the new answer and this is what we have to do. And in general, they have not panned out to be the great answer that everybody said. I strongly believe that nutrition is important in the sense that when we do not eat well, we will feel worse, we will have more fatigue, we will have a loss of energy, and we will have poorer healing. But unfortunately, when we start trying to decide that we're going to choose one food and that's the evil one, and we're going to choose another food and that's the great thing that's going to heal us all, we're in big trouble. And I will basically go back to the Trend Symposium of a year ago when we had a discussion about diet. And we had some really good talk about what we know and what we don't know. And what we really know is that probably some of the best things to do are stay away from fast food, keep to a good variety of foods and grains, and make sure you get enough nutritional benefit out of your foods. Eat plenty of fiber so that you don't have a lot of constipation and other problems like that. And actually, I'll quote what Alan said, Alan Bowling from last year. He says, "Eat food, not too much, mostly plants."
I would agree that, certainly there are lots of diets that come and go, and patients come in and tell me about their diets that they're doing well on. And I agree that I agree with the judgment issue, and that's probably not going to be the same effect in all patients with multiple sclerosis. However, I definitely am for a more healthy diet with less processed foods, with plenty of exercise that is capable to be done. I think that's good for everybody, whether or not you have multiple sclerosis or not. So I can't argue with some of those principles. I do think some of the things that we are learning about with study in MS, with the importance of vitamin D and adequate intake, and then salt, high sodium intake was associated with worsening MS. Those one things that were presented at the big MS conference in Europe last year. So salts and processed foods. So I think that that's healthy, but I think we should wait and see what information comes from the Walls diet being studied right now in a more controlled fashion to see how that's applicable to everyone with MS.
Thank you for that. A question about the differences between seizure and a stroke. How can you tell the difference between the signs of a seizure and a stroke?
Stroke tends to happen all of a sudden, as well as seizure. Both happen really suddenly. Stroke is caused by an artery getting blocked of blood from a blood clot or a plaque. You could have a bleeding type stroke or a hemorrhagic stroke. Depending upon what artery is blocked, depends upon what kind of symptoms that you're having. So it tends to be generally one-sided body symptoms that are sudden. Weakness, numbness, maybe trouble with speech. That happens just boom, you're fine, and then you have that. A stroke, though, causes permanent damage. If it's not reversed and the blood flow isn't restored, that part of the brain dies. And then, there is permanent damage there. Other parts of the brain can come help out with therapy modalities over time, but there tends to be permanent damage. A seizure, there are many different types of seizures. It's also sudden, but that's more from abnormal electrical firing in the brain. That can be in a local area, so that might be just face twitching or hand shaking that's temporary, but then it can spread over the entire brain, and you can have grand mal seizure with shaking all over. Grand mal seizures that go on uncontrollably can cause permanent brain damage as well, but generally seizure is a short, limited phenomenon that doesn't cause any permanent problem.
You can get a seizure from a stroke. And you can also, usually with a seizure, you get some sort of change in consciousness. The person starts being either unconscious or they're really not with you. With a stroke, many times, but not all the time, the person is still awake and alert and functioning, unless it's a really big one.
Thank you. Question, I've been told that getting overheated and breaking out in a sweat while just shopping is neurological. Is this true?
No.
Okay, we both agree? All right, we'll move on. um, let's see. I was diagnosed with MS 20 years ago, the question said, at KU Med. My life has had too many ups and down changes. What can I expect in my later years? I have been on Avonex for over 20 years. There was another question that asked, what happens when I turn 65? My doctor said I would have to go off of Avonex. So can you give a little discussion about that?
Well, first, nobody knows what the future is going to hold for any one MS patient. I have seen people that gradually got worse over time when they got older. I've seen people who seemed to stay the same as they got older. I've had people stopped having attacks as they got older. I don't know what will happen to a given individual as they age, except that we will all get weaker, we will all lose our balance, and we will all die. And that's, whether you have MS or not, those things are going to happen.
Don't forget about taxes.
Okay. But in general, it is true that people have fewer exacerbations as they grow older. But some of them trade that for a gradual worsening. There is no hard and fast rule that says when you turn an X time that you're supposed to stop medication. And every person with MS is different, and so I make a different decision on whether the person should continue on medicines, what they should continue on, and how they should do that, as we discuss that with each person.
I would agree, but I think we're probably still gathering information on how long, what the benefits of long-term medication may be. You know, we've barely had the disease-modifying therapies for 20 years, so we need to gather more information about that. I do make an individual decision about patients, but I tend to leave patients on therapy mostly.
Thank you for that. There's a delay. Sorry about that. What is the latest research information on controlling tremors?
Very bad. There's not a lot of information on how to control tremors, particularly from a research standpoint. I don't think there's a lot of research on that. There are there are medications we try from time to time, mostly coming out of the Parkinson's world and the essential tremor world, and we certainly use some of those medications in trying them in our MS patients. There have been some small studies looking at some of the deep brain stimulation in patients with MS that have had conflicting results.
Good, okay. A question about a device, and we'll probably pose this to two panels, but the question says, we are listening to a program on public radio featuring a person who developed an eating spoon for persons with tremor problems. Are you familiar with this device and its effectiveness?
I'm not familiar with the exact device, but definitely devices for helping with tremor or things such as weighted utensils, maybe things that are heavier, I know have been around for a while. I've had patients show me things that they've been able to get to kind of stabilize their hand to help enable them with writing and other things with eating. I think sometimes using weights on the wrist and making it a little heavier can sometimes help do things. But again, patients' responses to those things are different.
I'd say that's true. There are a lot of different devices, and and I think the OTs will probably be able to talk a little bit better about that this afternoon, because there are a lot of ways that people modify pens, pencils, eating utensils in order to compensate for various disabling activities. And that's what I'm talking about with technology. You know, we have wonderful technical advances like that that will really sometimes be a key to allowing somebody to move or walk better, or eat better, or write better, or whatever. get around their home better.
Great. Question around WeFit. This, again, will probably be posed in the next panel as well, but is it beneficial? Do you know of any programs that could be used to help with gait and balance?
Do you want?
I think WeFit is beneficial. I mean, maybe not for every single patient. It depends upon their problems and their issues related to it. But I mean, I've recommended WeFit for balance for patients other than patients who have multiple sclerosis. Just as you age, our balance does get worse. So trying to keep practicing it. If you don't practice, you don't use it, you lose it kind of thing. So, I think that could be beneficial.
I think it can be too. I have several people who have told me that they were using the WeFit, and can be used for balance, or it can be used for aerobic exercises. And there are several different programs that they use for it. Like many things, some of it, if it's fun, you will do it. If it's not fun, you won't. And one of the keys to a good exercise program is to find something that is at least enjoyable enough that you'll keep doing it. So if that's WeFit, if it's a yoga class, if it's a Tai Chi class, if it's walking around your neighborhood, water aerobics, if it's an exercise bike with a spinning class, if it's a new step, whatever it is, if you enjoy doing it, it will be a lot better. And so that's one of the keys to the WeFit, I think, is that it does, for some people, become kind of a game.
Great, thank you. Do you have any information on assistive technology for progressive MS that you would use with your patients?
That's a very individual thing. It really depends on that particular person. As I said, we use different types of things for foot drop, depending on if they have a foot drop. If they don't have a foot drop, we don't use it. The same goes for arm technology, or for the Dragon Naturally Speaking, or the the apps for all the different things you can use on your cell phone, which I don't have, so I told you I must Luddite. But basically, that's where the OTs, the PTs, and us kind of have to sit down and say, on this particular person, what assistive technology will help that person, rather than saying, oh, I use this on all people with this disease.
Right. Completely agree.
Wonderful. So last call for questions. I have two more right here. What information do you have about the Consortium MS in St. Louis?
I don't have a lot of information about that. I have the information about the Consortium of MS Centers, which is not in St. Louis, but is an international organization. And that's basically an organization that sets up meetings and training programs and discussions. They have at least one yearly meeting and several other discussion groups. They also sponsor NARCOMS, which is an online survey type of thing to try to gather information about MS patients in general. They sort of help to sponsor research and learning about MS. And so I know about that. I'm not quite sure what Consortium MS in St. Louis is about.
I don't know about the St. Louis.
Okay, thank you. If you haven't had an episode in over 10 years, are you in remission?
It depends. Technically, yes, if you are also not getting worse.
Right. I would agree if you're not getting slowly, progressively, slightly worse.
Okay, any other questions today for Dr. Lynch or Dr. Botwell? Okay, well, thank you both for sharing your expertise and time with us. Yes, round of applause, please.
Thank you.
And then there are wheelchairs.
So what I did here was kind of summarize, and you should have this, I think you guys have this in your packet. I summarized the 3 basic kind of wheelchairs. Wheelchairs are really complicated items because they're expensive and there's a lot to buy. It's sort of like buying a car. Manual wheelchairs are typically used for people who have good arm function and control and strength. They're portable, they're less expensive. For a lot of people with MS, though, hands sometimes do become involved, and so something like a scooter or a power chair that doesn't require as much hand strength and function and also better endurance, it enables someone with less endurance to function better over the long term can be better. But regardless, if you are thinking about getting a device, you really should get the assistance of a PT, but I'm gonna talk about that. So some signs indicating a need for a device or a change in a device might be a recent exacerbation or worsening of symptoms. Certainly a history of imbalance and falling. Poor balance performance is the leading indicator of fall risk and poor balance. A fear of falling, including a tendency to hold on to objects when you walk. So if you're holding on to furniture, pay attention to things that you're doing without maybe thinking about it. That automatic tendency to hold on to something might indicate a need for a device. Any numbness or sensory loss in the legs, leg weakness or buckling, certainly endurance difficulties, and having to concentrate when walking. And if you're having to concentrate when walking, consider a rolling walker. That's probably going to enable you to not have to pay quite as much attention to sequencing of steps and moving the device. Also, severity of imbalance and or leg weakness, and again, if this is more severe or if it affects both legs, consider a walker or wheelchair. Presence or severity of sensory loss. If sensation is your primary symptom and strength and balance are generally fairly good, a straight, simple cane might give you enough sensory feedback to enable you to function a little bit better. There was a study done a number of years ago that showed that just a single fingertip support can give someone some sensory feedback to make them walk and balance better. Endurance, again, if that's a problem, a rollator walker or wheelchair might be best. And then for wheelchairs, if you have problems with skin integrity, incontinence, posture, trunk control, and sensation, you might need specialized seating. Standard power wheelchairs, as opposed to scooters, are more able to accept different seating systems that can accommodate for extreme imbalance and postural deficits. You also need to consider your home environment. Obviously, if stairs are present, cane, crutches, and a manual wheelchair are probably more feasible than something power. Your community and whether or not you have unlevel surfaces that you're having to traverse that might impact your selection of a device. Your caregiver assistance and whether or not they can assist you as well as helping to manage that device is an important consideration. And lastly, but probably most importantly, finances and insurance, because ultimately you need to get payment because these things aren't cheap. The other thing to keep in mind is that generally insurance companies will only pay for one device at a time. So if you need a walker for walking and a wheelchair because of fatigue issues, you want to know whether or not your insurance will pay for both. And your social worker that you work with or case manager can help you sort that out. So when to seek opinions of PT? My advice is, and I don't want this to be just a sales pitch, my advice generally is if you're considering a mobility device or if you're having more significant balance or walking impairments, I would encourage you to get the support of a physical therapist because they will look at your overall picture and help match your goals, your needs, your level of function to whatever devices are appropriate for you. If you are considering powered mobility, I would strongly encourage you to get the opinion of a rehab team, PT, OT, the wheelchair vendor, social worker, case manager, because those things get very costly very quick, and there's obviously also hand function that needs to be included, and your friendly OT will help you out a lot with that. Okay. Lastly, I do have a bit of a sales pitch, I must admit. I'm currently working on a research study. I'm actually working on two. One is a survey. If you have been a consumer of PT services and would like to give your opinion about those services, you can talk to me after this session is over. I'll kind of mill around out near the registration desk. I can tell you more about that study. And then I'm actually conducting a research study with students at Rockhurst University right now, where we are looking for people who can walk up to 50 feet, who have MS, who would be interested in participating in a balance and mobility study. It's just a 2-time thing. We're looking at an outcome measure or test that we use, and we're trying to find out, is it reliable in people with MS, and can it detect change? Because that helps us as therapists know that we're heading in the right track with our interventions, and also helps us justify that our patients need care and are benefiting from it. So if you're interested in either of these studies, you can see me outside afterwards. I'm going to skip my summary so I can pass it on to my colleagues over here. And then lastly, I have some additional resources here. And again, you should have this handout, so you can look these up on your own, but there's just some nice little short video clips that I found online that help you figure out whether or not you benefit from a device, and if so, what type. Thank you.
Good afternoon. I'm Sandra Nugent. I'm a speech-language pathologist, but I normally say speech therapist because folks kind of know what that is. I know when I first was studying speech-language pathology, my uncle was confused, and he thought I meant, remember Quincy, the forensic pathologist? So I go with speech therapist most of the time. It's less confusing. I have a very low-tech presentation for you. I've got my nice paper here, no slides, but there's a lot of things we can do, and I'm going to go ahead and use one of my memory aids, which is my timer, to tell me when 10 minutes have gone by. Okay. Little tip, you can use that too. So we speech therapists work with folks that have memory problems, that have problem-solving issues, reasoning, judgment, and then what you kind of figured out already, folks with talking problems, understanding problems, reading, writing, and swallowing. So I usually tell people I work neck up. At the rehab hospital I work at, Mid-America, I understand when folks aren't used to a certain discipline or line of work, they kind of think we can do it all. Well, can't you do my PT also? Oh, you don't want me doing that. So I've been blessed to be able to work with patients and their families for 24 years, and everything from MS, stroke, brain injury, Parkinson's. I had my hip fixed. Even that can cause some memory issues. What I've learned is my job is more of a problem solver, to work with you and your families to figure out what we can do to make life more manageable and hopefully more enjoyable too. When I did a little research and kind of meshed that with what I already knew, the research indicated that the most common cognitive difficulty in persons with MS is slight short-term memory, well, moderate to minimal short-term memory problems, as well as trouble with working memory. So it's that new information that gives folks trouble. They can tell you where they worked, they can tell you how they met their spouse, they can tell you all sorts of things. But every now and then, because it's intermittent, it's not all day, every day, it's not clicking as well for them. And so because it's intermittent, you can use that to your advantage. You can use those better times, your good times, to kind of plan for, not in a sad or sick sort of way, but plan for your not as good times. Those good times are when you want to try out a new strategy or practice it a little bit. So I'm going to talk a little bit about kind of maybe reframing things a little bit. I've heard from many folks over the years, well, I should be able to do that. I've done that for years. That's so easy. But if you think about it, a lot of the things we do every day are pretty complex. We may do them every day. Driving, dressing, showering, eating, cooking, taking care of kids, taking care of grandkids. It's not 1, 2, 3. It's often 1, take this over here, use that over there. There's a lot to combine. And, you know, when your cognition is working well, it's not one part of the brain, it's lots of parts. So prepare yourself for the fact that while it may have seemed easy at one time, you were just super duper and you were doing something hard that you could do effortlessly, that now you're realizing when you're not having a good day or a good hour is harder. Stay conscious of how you're feeling. If you feel like your abilities are strong, then do some of those harder things then. If you feel like, oh, this isn't a good time right now, see if you can put it off a little while if that's possible, or ask for someone that you trust for help. And make the most of those good times. When you're noticing you've got the energy, everything seems to be working smooth with your memory and learning new things, you know, take advantage of that to kind of, like I said before, to rehearse and develop some of those strategies. Memory strategies. If you've ever been my patient, you should know these. There's 5. The first one is attention. And a lot of times I draw a really sad picture of an umbrella and put the word attention on it, because attention kind of covers all of the other memory strategies. And I don't really mean the attention we got in trouble for not having when we were in 2nd grade. What I'm talking about is, you know, there may be something on your mind. It may be internal. Oh, I got that bill to pay. Oh, you know, I'm worried about such and such. It could be something good. Grandkids coming. I can't wait till this happens. I'm so excited. It could be noise externally, something outside of you. You might be hungry. You might be sleepy. All of those things will cause you not to be able to take in new information very well. So I think about it kind of like if, you know, when you've been driving, and you notice that your attention's starting to waver. I bet you have your own kind of mental list of things you do to try to make that better. Okay, I'm going to turn on the radio. I'm going to turn up the air, roll down the window, stop for a cup of coffee. But if those don't work, you know you've got to do something different. If somebody else is with you, you switch drivers. If not, maybe you pull into that McDonald's and take a little nap, okay? So my point is sometimes you can change the situation. Can you come closer? Could you shut that door? Can we get the TV off? Whatever it might be. Sometimes you can't. And so you're better off, in my mind, surrendering and just saying, can't do it right now. So you look sharper if you let the folks around you know, now's not a really good time for me to hear about that. Could we talk about that a little later so that you're still in control and you put it off? If it has to be told right then, have them write it down. Have another person take the information for you. If the conversation had happened 2 hours later, you might have been fine. But at that particular time, it might not be a good time. And once you realize that, you're able, I think, to better kind of cope with these intermittent symptoms. Okay, so the next 4 are repeat. This is not rocket science. You're going to think, boy, I know that already. Great. Repeat. When you hear something again, do something again, see something again, it becomes easier. So whether that's going to your doctor's office the first time, you're thinking, oh my goodness, are we ever getting there? It just seems to take so long. Second time, it seems a little quicker. Third time, no sweat. You could tell somebody else how to get there without even looking at your notes, okay? So that repetition, whether that's somebody's name you're trying to remember. I've worked with folks before that they're trying to remember the new grandbaby's name, and it's not Ashley or Scott or something. It's kind of unique. And so we come up with little strategies. Well, how are we going to remember it? You can write it down. It sounds like, all of those things. So that repetition can help. So every time you talk about your new grandbaby, use their name, and that'll be another way that it'll get in your mind. We pick on used car salesmen, and I don't mean to pick on anybody, but they've got it down about learning our names, right? You are Scott? Okay, Scott, what will it take to get you into this car today, right? They use our names a bunch, but they remember our names. So something to think about if there's something you're trying to put in your mind, maybe it's a new medication you want to ask your doctor about. Well, of course, write it down, but you may want to, when it comes on the TV, if it's one of those, repeat it with them. Do something to help it get in your mind. Okay, that's repetition. The next one's association. That just means using what you already know to try to remember something new. So let's see, if I meet somebody named Susie, and I can think of another Susie I know, I can associate those two, and I might not even tell Susie I've done that. Kirsten's easy. Kirsten, I had a Kirsten in high school, and it's a unique pronunciation, so, but because I already knew one, I can remember, okay? So that's an association name-wise. There's all sorts of other ones that you can use. Write it down. Again, not rocket science. I'm sure you've done it before, and if you're feeling like, well, this isn't a handy time for me to write it down, it's no trouble to ask somebody else to do it. You're not asking them to write, an essay. You want them to write down just the facts. The last one is visualize, just means make a little picture or a movie in your mind of what you're trying to remember. Sometime when we have patients at the hospital, they'll tell me, oh, I sent my daughter home to get my blue sweater. She couldn't find it. And I'll say, well, what'd you tell her? And we kind of figure out that maybe she always keeps the blue sweater in the hall closet, but her daughter looked in the hall closet and it wasn't there. So where are the other possibilities? And so you start doing that. Oh man, that is my timer. So I'm going to wind up my story and tell you about a few aids, because that was 9 minutes. The point is oftentimes when we don't put things back where we usually keep them, and that happens to all of us, we won't find them immediately. We will be sending people to the wrong place to get them. But if you kind of retrace your steps and remember you'd been out to coffee with your friends, and darn it if you didn't spill something on yourself, and it's in the laundry room, okay? So sometimes that working backwards can help us. The other thing is probably we need to be flexible, and the white sweater would be fine too. Okay, so some memory aids that you can use, and I bet at least half of these you're already using. Post-it notes. My opinion is don't use them for everything. You'll spend all your time trying to figure out which one is addressing what you were looking for. Use them for the important things, okay? If you want to keep a running kind of notebook of what you're trying to remember, what you need to do, that's not a bad idea, because then you've got one place to go to. Calendars. Okay, we've got old school paper calendars. I know I still use one, but you've got your online or computer calendar, Outlook. I think it can be merged with your smartphone. I don't know, I'm still working on that. But arranging your environment. If there's some activities that you do all the time, whether that's paying bills or whatever, try to keep those supplies together so that you're not wasting a lot of energy and effort going to hunt for something only to realize that, what was I going after? So it's a good idea to keep those things together. And I kind of already made a plug for trying to keep things where they belong. I don't mean to sound like your mother, but I've found in my own life it sure makes things easier when I know where my keys are. So even though I don't want to be all stiff, there are certain things I've gone ahead and found a place for. Okay. Combine activities. If you're having trouble remembering taking your morning medicine, but you never forget to brush your teeth or clean your dentures or whatever it might be, put those two together. When I brush my teeth, I take my medicine, assuming that that'll work with what the doctor's recommended, so that you put two things together. I do this anyway. Talk to yourself while performing a task. If you kind of talk yourself through it, okay, I've done this, now I need to do that, that can kind of, during those tough times, kind of keep you on task. And also getting to hear it as well as think it can help it be more smooth. Okay, sometimes you may need to ask for help. That's not fun, but it can be the wise choice sometimes. Alarms, timers like I used, I've learned I don't use the timers that quit on me. I use the timers that keep going until I go turn them off. I don't know how you all feel about that, but I've burnt a number of things in the kitchen before because my hearing's not so good. Some folks have said they enjoy using electronic pill boxes. That works for them. I think a timer set on your phone or a timer on an alarm clock that has 2 settings on it can work just as well. Emailing yourself reminders. Anybody else done that before? I think it can work really well. So there's, like I said, it's not rocket science. It's finding what works for you and trying to make life during those times that are a little harder go a little smoother for you. Thank you very much.
Hello, my name is Susie Wiley, and I'm an occupational therapist. We have all combined, as I tally up our years, we've been around a long time, I'm seeing. I too graduated in 1985 from Ohio State and have worked at the Rehabilitation Institute in many capacities over the course of the years, and with all populations who come for services at the Institute. Over the last 15 years, I have primarily worked in the area of assistive technology, which are some of the less traditional OT forms of technology, which for those of you who have experienced work with an OT in the past, it may be along the lines of reachers, some type of a button hook, any type of adapted utensils. But what I'm going to talk about today is a little bit less traditional, and I'll bring up my own here so we can get started. The areas I'd like to touch on and just give you a brief snapshot of today are those tools that can help with computer use and computer access, and anything anyone's wanting to be able to do, whether that's email or staying on Facebook and keeping up with everyone on Facebook, as well as forms of communication, any form of communication, whether it is because of spoken communication needs or the written communication tools that are necessary. And just part of our everyday life. And almost everyone, 98% of folks in the United States now use some form of computer access. And that's staggering to think that so many of us are using computers already in our everyday life. So we'd like to continue doing that. Access to print, we will discuss a little bit in talking about being able to read and tools to help with that. And we'll touch on home modifications and some of the less traditional home modifications to consider and just be aware of and be informed of. The areas that we want to just briefly look at for what helps us determine what technology would be beneficial to adapt is what may be going on with our vision, what may be happening in some of the areas that Sandra mentioned in the way of learning new activities, or are there ways that we can minimize what we need to learn to be able to still do our email and not have to learn very much with the new tools we're needing to pull in, as well as the physical skills and being able to continue using our systems and whatever our technology is in whatever way possible. When we talk about vision and some vision changes, often everyone thinks of acuity, and I have 20/20 vision, which I am far from. But I think the other areas that we need to be so aware of are visual fields, and maybe not such a clean perception of, I don't see this half as we do in strokes, as much as some spottiness in our vision, and how that impacts what we want to be able to do from a technology standpoint. I might have difficulty reading, or I might have difficulty locating certain items on a keyboard or looking at my phone. So what tools might we need to explore to make that continue to be a skill we can continue to do? Having contrast sensitivity means black on white. That is very high contrast, but you see the example down in the lower right that it varies in contrast, and that therefore affects how well we can read or see something. So if we need something high contrast, how can we make the tools we want to access have that high contrast sharp as it can be for us to see? And eye muscle control, we have 6 little muscles that hold that eyeball in place, and that's a lot of muscle control. So if we start having difficulty with some of those muscles, as we do any of our other muscles, it may impact the ability to hold our gaze, particularly on a set spot, or to track to read. So you see the example there of that moving text. Don't be alarmed, that is really moving. So, and it's moving, so it's all okay, it's good. But it does give you a sense for what it is like. It's not truly double vision. It's just difficulty getting the image to fuse, which can make reading extremely difficult. Doesn't mean you can't see. It just means that reading is going to be a task that may be incredibly difficult. So what do we do? What do we help explore and identify, and what's out there? There are tools, there are apps, free apps that are downloadable to make your phone a magnifier. Some are better than others. One called Magnifier is a very good one because it doesn't require holding that position for a long period of time before it catches that snapshot, but it'll catch the snapshot and lock it in and magnify it. There are many others, but again, it's just so many times it's just researching them and reading the reviews. Folks have really good opinions on some of these, and some will tell you, my hands tremor too much. And these are not, by any means, these are not apps just for folks with disabilities. We all need magnification at some point for something. And so that's just the best example I can give. Again, looking at the contrast, you can kind of see on the one device in the top right, just the difference in that contrast. You don't realize how many things we look at that are kind of black on gray. That's a very low contrast opposed to something that gives you a sharper view. And then enlargement, just giving enlargement, whether it's on stickers that can be placed on a keyboard to give high contrast and enlarged letters, or the enlarged keyboards like you see in the bottom right. Access to print, whether it's to read books, to read email, to have access to our social media, having the ability to have information read back to us. Even though we may see it, if our eyes are adjusting as they were in that one slide, we're going to have a difficult time reading our emails from our family members. And so there are software tools that can read back to us the information that we want read to us off of the computer screen. This particular example actually takes a snapshot of a book or a page, so it may be something like a bill, and it'll take a snapshot, put it into our computer, and then read it back to us for folks that may want to be able to read letters from a doctor or something they've received in the mail. Communication tools, this is more for spoken communication, which we don't see as much need for, but just to be aware that a lot of the communication tools, especially the high-end devices, also give us access to computer functions. So not only does it give us the ability to have spoken communication, it also gives us the ability to have written communication in whatever form that might be. But how to use these tools, we need to know and explore the physical access methods. And in light of that, as we look at these different devices, one may be just using one hand or a couple of fingers to type. My mother always felt the need to put her hands in the proper home row and never felt like she could just let it go and use her one hand to type when she needed to eventually. And so I said, you can look at the keyboard. Don't worry about proper fingering anymore. You know, just do what you need to do to get done what you want to do, what you want to accomplish. And so whether that is I just want to do email, we can create shortcuts that essentially go right into someone's email and then actually use keyboard shortcuts and learn those couple of tools or write them down on a list, those keyboard shortcuts, to be able to bypass use of a mouse completely. So that just as someone who doesn't see the computer screen, they use keyboard shortcuts, so do some of us that have difficulty using a mouse. And in spite of trying trackball and a joystick, it may be most beneficial to just do some keyboard shortcut, meaning keyboard combinations. Voice recognition software, you see the gentleman on the left using voice input software. That is where you speak and the text hopefully comes up on the screen as it was spoken. If it was to the Star Trek level, I think we would all be using it, to be quite honest. Voice recognition software is an amazing tool. It's very powerful, but there are components of it that do require a significant amount of monitoring what is up on the screen. So it requires our vision. It requires our attention to remember, okay, what did I say? And now that I'm reading that, how does that compare with what I said? And then knowing the commands to make those corrections. And so all of those components make it very helpful to try this type of a tool out before you would purchase that. I'm an advocate of really make informed decisions on equipment that you may use and try. I want to talk briefly about safe mobility in the home. And again, I'm not talking about some of the low-tech, very necessary tools like grab bars. They're incredibly needed and useful, but I also want to open your eyes to some of the other modifications that may be done and make you aware of when modifications are made, think long-term for anyone, not just yourself. I want my bathroom to be accessible to my in-laws regardless of their age or what disability they may have if I'm going to make some modifications. So if you can think along those lines, you won't be necessarily thinking, well, I'm having trouble walking into the shower now, so I just want to make it that I can walk in easier, but it's too narrow to put a lift in at some point. I want to think, what would let anyone be able to use this shower ever if I'm going to put that kind of an investment into my bathroom? And as you can see, this one would allow someone to, it was modified from a traditional bathroom to a roll-in stall. It actually has a little ramp up to the curb because there is a slight curb. And a lot of times, folks, we'll talk a little bit about who the different participants are in this process, but it's very important to just make yourself aware of who those participants are and making sure that everyone is talking the same language. Just briefly talk about the ramps to a home, just reviewing the ratio that we try and help folks understand is that for every 1 inch of rise, there would be 12 inches of ramp for someone that would like to navigate that ramp independently. Power wheelchairs can manage a 1-to-10 ratio quite easily and safely. And I put this in here to be aware of portable ramps. I think a lot of folks look to portable ramps as being an option opposed to doing something what they consider permanent. But portable ramps truly tend to start losing their portability at about 6 feet, which that, when you think about it, that's only a 6-inch rise, a 6-inch step. So the better solution may perhaps be an actual ramp being constructed, because when you get to the top of that portable ramp, you do need a flat platform to be able to position on so that a door can be opened without rolling back down the ramp. So think about what would need to be done once you're at the top of that ramp if you were really considering a portable ramp, and think about the length of that if it really is going to be portable depending on the length. Find out the weight. And threshold ramps, I think they're an unsung hero. They're nice little ramp. They're portable. They just create like a wedge that can go against a threshold that may be up to 2 inches tall. So sometimes your front door thresholds can be rather high. And you can find threshold ramps online, just shop for them online. Some are a very heavy-duty rubber. Some are actually an aluminum. But they'll say they'll do a height of up to 4 inches. I don't think 4 inches is a threshold. I think that's a step. So, but I think up to 2 inches, you're real safe. And ramps can be they can be as simple or as beautiful as a person would want them to be. This family decided not to take up one of the garage bays, so they actually put a door on the outside, and when you came out the door in the garage, they extended out and built another door that then allowed them to access the driveway from the ramp that they added on. Whoops, sorry. I'm over, sorry. Lift systems. I want to talk a little bit about lift systems because at a certain point, ramps may be unrealistic. If we have to make an entire flight up to the main level of the home, that would probably make a couple 100-foot ramp. And that's just not realistic from the standpoint of navigation, being protected from the weather, that might not be the option to go with. So it's good to be knowledgeable and just aware of lift systems that are available. I gave an example of each. A stair lift, something to consider with stair lifts is that there does need to be some form of mobility at each end. And I consider a stair lift an option for folks who just have a little difficulty with mobility. They might not be safe going up and down the stairs. And again, I like to think what's going to be useful for anyone at any time. So if I'm going to make this investment, I'd like it to be something that can work for our friends that come to visit that use power wheelchairs too. Even though my mother uses a manual wheelchair, if we're going to make that modification for her, I want it to be any weight and any ability. Vertical platform lifts are often used instead of in residential elevators. And you see the picture there. Most of us see vertical platform lifts when we go to the airport or to a stage such as this. It's those portable, oftentimes lifts that can then elevate you to another height. They can actually transverse 2 levels of a home. So they're constructed inside of an elevator shaft, and then it would allow someone to go to the multi-levels of the home. Significantly less expensive than a residential elevator and quite durable and offer quite a bit of dependability compared to the low-end residential elevators. Incline platform lifts, this is the type of a lift that you see there with the stairs. The greatest drawback with that, and they're great lifts if you have the space for them. They allow you to roll straight on. You get to the bottom of the stairs and you can roll straight off, but you need 9 feet at the bottom of those stairs. So oftentimes there's a wall or something at the bottom that you're not going to be able to navigate that. So that's one of those considerations. Ceiling lifts. Ceiling truck lifts, I have a clip of video for you. I'm just going to have to leave the presentation here in a minute to show you the video. But I bring this up because they're very unobtrusive. As you can see from this bedroom example on the left, the bedroom before the lift was installed is down there at the bottom picture, and then the top picture shows the ceiling lift. What that is, it's a motorized lift that once the sling is attached to those lift hooks, then the motor gently lifts someone up and allows one person to easily help the transfer of that individual. And so when we're talking, and if you're interested in kind of talking prices, we're talking probably $6,000 to $7,000 for a ceiling lift, but it allows one person to help with transfers, particularly when they're difficult transfers, and it's very safe for everyone, both the person that's being transferred as well as any caregiver. Doesn't matter on their size, they can be trained. It's a very clean method of transfer. And the way the slings are made now, they come down behind the back and the bottom is left open. So they come under the legs and come up and attach. And I'll show you the video. And it's a 2-minute video, and then I'll be done. So, escape. You taught me that trick. There we are. Sorry, the sound. So some ceiling track lifts are, actually the motor can be detached and taken to another room. So some folks may want to be able to transfer in the bedroom, but they also want to be able to do transfers out in the living room onto a recliner. This particular one, the motor, as you can see in that picture behind it, right over here, this one is attached up at the track. It charges, it's a rechargeable battery unit. And this takes 2 minutes, and this is me doing the transfer. I'm not the slickest by any means. So as you know, it can get very fast. This can be done in less than a minute. Too long. If I knew how to fast forward on this one, I would. Sorry. I'd make it motor along. Whoopsie. The weight limit, sometimes folks will ask, what's the weight limit for these? It's 300 to 400 pounds is what the motor is identified, but I've worked with contractors and DME installers that are highly experienced with these lifts. And they've been able, what you can also do is, depending on your structure, they can reinforce them to be as strong as they need to be. And then if it does require a second motor, you can actually do a dual motor. And obviously I'm behind her because I didn't want my back to the camera, but you wouldn't normally be hung by the cord there. Trying not to laugh there as I'm trying not. And you can see she's going down into the roll-in shower chair. And as it's lowered, you compare this to like a traditional, what we all refer to as a Hoyer lift, a floor lift, and how much easier this is to navigate. It can just be slid essentially with one hand to help glide someone, and then lower, and then unhook. And then that sling, I'll stop the video, but you just lean the person forward and lift the leg, take it out from under, and slide it out from behind their back. Okay? Okay. My last point I wanted to make was just who would participate in some of these. And I think it's real important to be aware of. There are folks who sell the products like that ceiling track lift. And it's important to have folks involved that are experienced in each one of these areas. That you might have a contractor who's willing to remodel your bathroom. And oh yes, I've done accessible bathrooms before. But make sure someone is involved that has helped you all decide, yes, this is exactly what I need. I know I'm covering all my bases. Because sometimes we just don't know what we don't know. And having someone offer some ideas that you may not have thought of yet can be helpful in making sure you're making informed decisions as you work with these different folks, whether it's the contractors or the folks who sell what we refer to as durable medical equipment vendors. Okay? So, thank you.
Thank you. Now we are going to have time for question and answers. Did anyone, if you have written any questions while you were listening, will you raise them up and we'll come around and get them? Otherwise, I think what we will do, there were some questions this morning to the neurologist that might have been better answered by you all. So some of these questions might be a repeat. And the first one is, we were listening to a program on public radio featuring a person who developed an eating spoon for a person with tremor problems. Are you familiar with this device and its effectiveness? And you can take the mics off too if you want.
I've seen the video. I've seen a video on the device. It's actually kind of a nifty little device. From what I understand, I've never seen it used in practice in a home in clinical care, but from what I understand, it's sort of like a device that actually looks sort of like this microphone, except it's a spoon on the end. And they designed it so that the device itself accommodates for someone's tremor. So the device within the spoon is some sort of mechanism that absorbs that tremor, which then decreases the amount of the tremor in the actual spoon as the person's eating. I don't know anything more than that. As always, and as Susie said, I think if you're ever going to try something like that, it would be a really good idea to try it out. Liftware spoon. Yeah. 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 There is, yeah, if you Google it, you will find it. There is a video. You know, I would say a low-tech item might just be to try to weight down your wrist or use a weighted utensil, and an OT could certainly help with that.
We did have an individual purchase that, and he had too much of a tremor to effectively use it. So if that helps to know. And he had a fairly significant tremor, but I think that's when you go to trying something like that. So if that helps, right.
Susan just asked me to repeat the name. It's called the Liftware Spoon. The other thing that you can do to help manage tremors are caused when people have difficulty controlling multiple body points and multiple body joints, multiple muscles, multiple joints. So any way that you can sort of constrain that tremor and constrain that limb can help. So even though it may not be considered polite, Eating with your elbows on the tables can sometimes just be a really simple strategy that works extremely effectively. Weighting down the limbs serves the same sort of purpose. Downside of weighting is sometimes people find that after they unweight, they have a little bit more tremor. But again, I would think that that would probably be temporary.
All right. Question number 2. Do you have any specific experience with the Dragon Speech voice recognition software?
Oh, yes. It's actually Naturally Speaking. Used to be called many years ago Dragon Dictate. Dragon Naturally Speaking is voice recognition software. There is a retail version, and there is a version which is called Premium. That is the version that's intended for folks with disabilities because it can allow control of everything, including voice input as well as navigation through your programs. I was mentioning before that is actually voice input or voice recognition software where you speak and you hope that what you said is what comes up on the screen. There are some pieces that folks often don't realize that all sound cards are not made the same. They are not all alike. And so there is a sound card adapter that we will never use that software without the micro adapter that bypasses the sound card in someone's system, because all the research and development on sound cards, for the most part, on the traditional sound cards we all get, are this for the sound output. You want to have good music. You want to hear your books well. Not as much research and development has gone into sound input onto sound cards. So in light of that, that sound card is not going to be the quality that it needs to be to handle voice recognition software. So if anyone has ever tried it and it just was a disaster, that is probably why. The other component of that is the sequencing. It really requires quite a bit of attention and new learning and sequencing to make it work for you effectively. And that's that component that if you've tried it and you've found it's very difficult to use, it could be any aspect of that that makes it difficult. And sometimes we can get around that with just some simple, straight commands, that those are the only commands that are used. Sometimes folks have difficulty learning any of the commands and they dictate and just let it be what it is. So that's the trade-off. But like I said, if it was to the Star Trek level, truly we'd all be using it. It really isn't there yet that we can just kick back and talk and have it recognize all of our speech effectively. I think we'll see it get there at some point, but it's not there yet. It's getting better.
All right, thank you. Oh, yes, we have a question on the floor.
George asked if we work with folks who are blind. Do you mean me or with the assistive tech? Yes. With the assistive tech for folks who are blind and if folks need a prescription. Regarding folks who are blind, if it is straight blindness and learning some of the strategies and the tools that are truly JAWS, and which is a text-to-speech program that reads everything on the screen and folks navigate by all keyboard shortcuts, we will train them on the use of that. Oftentimes, though, there might be other tools. If someone is not completely blind, they may be legally blind, per se, but they can take advantage of some of their vision to still use tools that don't take them to the point of having to do everything by JAWS. So we see folks for that. In regard to a prescription, it somewhat depends on the payer source of who's helping folks get the software they need. On the Missouri side, there are some payer sources that don't require that it be an OT or speech pathologist that see them for those tools. So therefore, it doesn't require a prescription for us to see them. But other times, if it's for medical need, then it does require a prescription. And we usually help, and I'm sure everyone just helps in getting those scripts to say what they need to say. JAWS is a tool that's used for, one of the most common tools that's used for text-to-speech for individuals who are blind. But Zoom Text is an excellent tool for folks who can take advantage of some vision and have magnification, but still need that speech feedback. Whereas JAWS gives you no magnification because it is truly built for folks who have no vision. So it doesn't do any magnification, doesn't highlight as it reads, because it realizes the user isn't seeing that. Yes. Yes, it was designed by folks who are blind. For our assistive tech that I just spoke of, that can go directly to our intake person, which I believe, Nancy, do you have brochures? Yes, Nancy back there. Our brochures have our contact information for that program, for our assistive technology program, and it's pretty comprehensive in explaining all the different programs, but there's a contact number, and again, it can be a self-referral. And then if it does look like it's going to require a prescription, then we walk through all of that in getting that for someone. So folks can call, because our intake nurse is amazing at kind of triaging calls. And Erin will take the call and think, oh, okay, this person, sounds like the right fit for you. And then they'll walk folks through the process on how to access services. I think yours, same way.
Okay, there were a few questions, and I'd like to ask these again. Well, I'll ask that second. One just came up, and it said, what agencies in the Kansas City area can be contacted to consult on home modifications for persons with disabilities?
As therapists or DME, like, are we thinking contractors, or more as having help to identify what would be helpful? I just want to make sure I'm understanding the question. Okay, then I know our program provides that. I don't know if, does Mid-America, do you all do that?
Let me turn this on. Hello again. What we generally do is for, I know, inpatient, and we've got some outpatient therapists back there. If the person lives within a reasonable distance, we definitely will do like a home evaluation and make suggestions for modifications. And I just guess I don't know if outpatient does the same. You do? Okay.
And I tend to see a significant number of folks for home modification visits on both sides of the state line. It came as a result of about 7 years ago, Johnson County had an excess of funding for their folks with developmental disabilities, so necessitated 40 home modifications being done in a 3-month period. So that is really where I was immersed in the whole ceiling lift, the many different types of floor lifts, because the funding was there for Kansas residents at that point in time, and they needed help in identifying what folks needed. So we've just continued to provide the service because we were able to gain quite a bit of experience with it. So as well as with the contractors and the DME providers, that it's been quite a learning experience.
All right, this question was asked this morning, but it would be interesting to hear your opinion. Several questions were asked about balance. One in particular, WeFit, and the programs that they have on WeFit. Do you recommend certain programs to enhance balance? Questions about exercise, how I can improve my balance. What do you think is the best things to do to improve walking? So questions, around walking and balance, and what you suggest people do to improve or maintain.
I'll go ahead and start this off anyway. I think Dr. Lynch kind of hit the nail on the head this morning when she talked about the importance of finding something that is fun. There are numerous different ways to go about balance and mobility training and improvement. And WeFit is a great way to do that. There are a lot of fun things that can challenge someone's balance. The potentially tricky thing with balance is that balance is multifactorial. And what I mean about that is that there's different aspects of balance control. This morning, Dr. Huisinga talked about the importance of sensation. That's one aspect of balance control. We also need to be able to maintain a static or still condition. That's another one. We need to be able to respond when someone unexpectedly bumps into us. We need to be able to respond when we go to reach for something or when we go to initiate movement. And then there's the strength and just range of motion aspects of strength. And any impairment in any one of these sort of underlying components of balance can affect someone's balance control. What studies have pretty universally shown is that balance retraining and the improvements that one gets from balance training is very specific to the type of training that they do. So if, for example, you're working on improving balance by doing reaching, you will improve in reaching, but you're not necessarily going to improve in functioning when you're in a dimly lit environment or when you're on an unlevel surface or when someone accidentally bumps into you. So, ultimately, if you're experiencing problems with balance, I would recommend see a physical therapist, find out what are the underlying problems that are impairing your balance, because it's very complex, but it's also very important to determine what are the areas that are difficult and challenging, because that's where therapy should be focused. And then your therapist can help you determine what might be most appropriate. WeFit, yoga, Tai Chi, there's been a lot of work done in Tai Chi, particularly in elders and people with Parkinson's disease, but it's very effective. There's the balanced body weight torso weighting that I briefly mentioned this morning. So there are a lot of different balance approaches, but ultimately it's really important that your balance approach be matched to your balance deficit, or you're not quite as likely to get the maximum benefit out of it. Same sort of thing goes for walking. You have to think about what are the environments that you're walking in, what are the problems that are constraining your walking. If it's spasticity and pain, that's going to be managed very differently from someone who has weakness that's affecting walking performance. So it's highly individualized, and treatment should be therefore highly individual. Does that help answer that question? I think there were a couple components to that.
Does anyone have any other questions? Because that was our last one. So if anyone has any last minute questions?
Just make one more plug. Again, I'm doing the 2 studies. I will be outside. I'll be waiting near the registration desk. If you have an interest in learning more about my study, that's the survey study, where we're looking at trying to understand what's important to you as consumers of physical therapy, or if you're interested in my balance and mobility study, I can talk to you out there. So.
Just as a transitional point between the panel and Rebecca's conclusion regarding the home modifications, I wanted to let you know that one of the state public policy issues that the MS Society worked on this last year was to pass a home access tax credit, and it did pass in the state of Kansas. So if you are a Kansas resident and you're considering doing a home modification to your home to make it more accessible, you may be eligible to receive a state tax credit for that work. So there are some guidelines, of course, about who is eligible for that, and I wanted to let you know about that possible revenue opportunity for you as you consider some of these home modifications. We have, I think we included it, Carrie, did we include that in the last MS Connection? And yes, we did. We had an article about that in the last MS Connection. So if you want to go to your summer MS Connection, specific information is there. And you can access that on our website as well. But I wanted to let you know about the work that the MS Society did. Our GRC chair was here earlier today, Mary Reed Spencer. We have at least one GRC member here present. Just make that connection between the work. that we're doing on your behalf related to public policy as well. And did you want to say?
Just to add to the tax information, if you have a physician's prescription for the durable medical equipment, I think most of us are used to insurance purchase with wheelchairs and some of this, but when it comes to the lifts, because that is often being paid out of pocket, that if you have a prescription, then you don't pay sales tax. So that's just something to be aware of and to get a prescription for if you go that. Yes, it is significant.
Really? True. This year, we just recently passed it in Kansas, but that was our public policy issue actually in Missouri the year before. So Missouri also reinstated their home accessibility tax credit opportunity. So there should be something available to Missouri residents as well.
Oh. Well, thank you, ladies, so much. And the doctors and everyone who has presented and been a part of this today. My name is Rebecca. I am a volunteer. I am a fellow MS patient, and I was part of the planning committee for this. We are so glad that you took time out of your very, very busy lives to be with us today. We hope that was very helpful, very informative. I'm hoping that I can retain just part of it and be able to process it. Rest time in the middle probably would have helped me absorb a little bit more, but that's okay. I took notes as part of my memory stuff. I want to take this moment, though. Hopefully I won't get fired for this. They'll just cut my pay. The ladies in the corner, they're just a few members of the staff that are left from the Mid-America chapter. Their day job is to make our lives better. And they see the word MS and multiple sclerosis all the time, all day long. And when it's easy, just like it's that way for all of us, we get used to things, they lose their significance or their impact. And this isn't a benefit. Programs like this are really good for them too, because it personalizes the word and the phraseology that they hear and they work for and they talk about all the time. But we wouldn't be here today if it weren't for them, and there wouldn't be the home health care medical equipment tax thing. If it wasn't for the society, guys, we wouldn't have that. So can we just say thank you to the Mid-America chapter? Yay! Yay, you! Good job! So, thanks. All of you. They've had a very big staff turnaround in the last year and a half to 2 years, and you wouldn't know it because the people that have come in to replace the people that have left have had the same passion, the same vision, the same drive and commitment to helping people with multiple sclerosis and to keep the movement going. Okay. I'm sorry to have to say it again, but the questionnaire thing, the evaluation form, I am the most indecisive person known on the planet, okay? I hate evaluation forms. If I say that I disagree strongly that they were wonderful, well, then I feel like that I am personally rejecting them, okay? And that's not the case. We really, really want your opinion, okay? We don't know what to do better or what to do different if we don't know. Now, on the back, towards the bottom, second to the last, what topics would you like covered? Seriously, if you have any ideas at all, please give it to us. Even if it's small, like, I can't even think of a small thing right now, but would seem I've before had an idea and thought, oh, for crying out loud, they can't have an all-day seminar conference thing on the idea I have. But it's possible there might be another idea from someone else and another idea from someone else that we could put together for an all-day symposium, if I said that right. So we would love to have any thoughts, any things you've wondered about or you would like to learn more about or could be benefited from. Pain management, bladder bowel control, relationships, whatever. If you have any ideas, because we do use these. We do. We read them off at the very beginning of our daily. Like, when we first start planning this. And then, okay, if you can breathe, if you can think, if you can talk, if you can come up with an idea, you can be part of our planning team next year. You don't have to leave your home. A warm body, yes, we'll just take. Seriously, and if anybody gets it, we get it, that if you feel good today, or decent today, and next summer or next spring, when we start planning this and you're not up to it, we get that, and it's okay. So you can sign up now, and next year, if you don't feel like you're able, then just say, sorry, not able to this time. But if you would love to be a part of our planning committee, we would love to have you be a part of us because it takes many, 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 many hands. I have talked enough. After you have done your evaluation, you may leave it at the center of your table. Thank you again so much for being a part of our event today. It's been a pleasure having your company all day long. Have safe travels, have a blessed weekend, and we look forward to seeing you next year. Thanks.